Please start.
Yeah.
Hello, welcome everyone in the audience from this IRSI webinar. This is the IRSI WebCliniX. This is the second of our webinars, which is basically an ophthalmic debate, the big standoff, and we have a galaxy lineup today. I will quickly run you through and introduce you to the topics for the day and the speakers for the day. So I'm Gaurav Luthra, and we will be coming on with the presenters. So today's lineup, we had a very successful webinar a few days back, and we went live on Swarnim, which is a J&J portal, and the Facebook Live and YouTube, and we had almost 5,000 viewers. So today's is also streaming live on Facebook and YouTube in case you are not able to log in, but you can only send in your comments through the J&J portal, which has been sent to you, which is on swarnim.com. So if you want to comment or if you want to vote in the polls, then you will have to log in on the Swarnim portal. That way we can see all the questions that you are putting up and all the panelists can see them as well. So welcome to the second debate. And we have our cowboys with us, the senior panelists. And we have today with us Professor Keiki Mehta, past president of IRSI, past scientific committee chairman of IFIS, one of the most renowned speakers. Dr. Lahane may join us a little later. He was not able to log in yet. We have with us Professor Mahipal Sachdev, chairman scientific committee of the IRSI, president of IFIS, and again, one of our senior, very renowned IRSI members. And then last but not the least, Dr. Mohan Rajan, who is also treasurer of the IRSI and one of, again, our most dynamic members, the OPL King. So going on, we will have several situations discussed today. And we have the cowboys who are going to be, the gunslingers. So we have, the first situation which we are going to discuss, and that's cataract surgery for an elderly male with refractory pupil on Urimax. That is a potential IFIS patient. And how are we going to operate upon him? So we have Dr. Suven Bhattacharjee, and he's no stranger from Kolkata. He will be speaking on how we can use the HEX ring and how he prefers that. We have Dr. S. Bharti from Delhi, director of Bharti Eye Foundation. He's going to speak on iris hooks and how he likes to use those for his IFIS patients. And then we have from Amritsar, organizer of one of our most popular winter IRSI meetings, Dr. Rohit Om Parkash from the Dr. Om Parkash Eye Clinic. So he will be speaking on how we can operate using no devices, just using other methodologies like viscoelastics and several other ways. He has some innovations up his sleeve. Now, once I finish with the three presenters, we'll have a panel discussion of 5-6 minutes. During this time, you are allowed to vote using the Swarnim portal, and you can send in your votes in the comments section by voting by putting the name of the presenter whom you agree with, or what is your preferred technique amongst the three. And that way we'll know, and we'll announce the results at the end of the discussion before we go on to the next situation. The next situation is going to be intracameral antibiotics. Now, these have become very popular, but they remain a little controversial. So we have the pioneer of intracameral injections and the one behind the biggest study in India, Dr. Haripriya Arvind from the Arvind Eye Care Systems, where they have published the biggest data in the world on use of intracameral moxifloxacin. She will be speaking for the use of intracameral antibiotics. And then against her and trying to tell us that it may not be necessary in all situations is Dr. Anagha Heroor, again, our senior AIS member and medical director of Anil Eye Clinic in Mumbai. A third situation is going to be on intraoperative PC break with inadequate support. And we have three renowned speakers, Dr. Ashu Agarwal from Delhi, who is going to speak about ACIOLs and how they are still relevant in certain situations and how to get them right. He's a cornea surgeon and works at the Indraprastha Apollo Hospital besides his own clinic. And against him is our young gun, Dr. Shreyas Ramamurthy, who is going to try and convince us that in certain situations, iris-supported IOLs may be the best way to go. He's again a very talented young man, cornea and refractive surgeon from the Eye Foundation in Coimbatore. And our third speaker trying to tell us that glued IOLs, which have become really popular and simplified by, Dr. Amar Agarwal and Dr. Mahipal and Dr. Ritika. So Dr. Ritika Sachdev, who's cornea and refractive and cataract surgeon at Center for Sight, New Delhi, will be telling us why she prefers to use the glued IOL. Our last situation is going to be post-COVID, will you consider simultaneous bilateral cataract surgery as an option? This has become quite debated in the US as well, because they're saying that the risk of operating can be minimized by having both eyes done at the same time. Now, is that a good idea or not? So debating here is one of the pioneers of simultaneous bilateral cataract surgery and a member of the, I think he's one of the chairpersons of the association, International Association, Dr. Cyres Mehta, who is from Mumbai, from the International Eye Center. He will speak for this. And Dr. Purendra Bhasin, who will be speaking against this. Dr. Purendra is again a very, very sound cataract surgeon from Ratan Jyot Netralaya in Gwalior. He is scientific committee chairman, I think, in Madhya Pradesh. So going on, and I am the moderator. I will be moderating this session. I think we'll quickly go on now. I'll introduce you to the panelists and the first two speakers, and then we'll go on to the our two presenters who are going to present. So we have us now Dr. Keiki, Dr. Mohan Rajan, Dr. Mahipal, and we have our first speakers who are ready with their presentations. So let's go ahead with the first presentation. I think Dr. Suven Bhattacharjee can uplink his welcome, Suven. So please go ahead, and you have 5 minutes. We'll be waiting for responses from the audience. Any questions you put up, we will be saving them and putting them up to the panel right after these discussions. Please go ahead, Suven.
Yep. Good evening, and thank you, IRSI, for this opportunity. I'm Suven Bhattacharjee, and I'll be speaking on the use of HEX pupil expander for cataract surgery for the elderly male with refractory pupil on Urimax. I do have a financial interest in the HEX pupil expander. Now, let me introduce my worthy opponents. The first is a great gambler, Dr. Rohit Om Parkash. He has imposed a self-imposed ban on pupil expansion devices. God knows why. But sir, for gambling to be successful, many must lose so that a few may win. My other opponent is Dr. Bharti. Now, despite being at the forefront of cutting technology, he expects us to believe that he is, in this current day, using bows and arrows and iris hooks. And sir, no one knows this better than you, that you can't do today's job with yesterday's methods and be in business tomorrow. The truth is that my worthy opponents use the HEX pupil expander regularly, and they are here just to keep the viewers humored. Now, on the table, my first job would be to identify whether the pupil is rigid or elastic. Now, you can't tell when you look at them, but then we need to understand that an elastic pupil is typically, it's stretchable, and it comes back, and it again can be stretched. Whereas a rigid or a fibrotic pupil does not stretch. Instead, it actually tears or breaks when you try to stretch it. So that tells us whether we require mechanical dilatation of the pupil before you use a pupil expander or a iris hook. So if it's an elastic pupil, you do not need to do any stretching. If it's a rigid pupil, you do need to do a stretching. Now, there are different mechanical devices like the iris hooks and the Malugan ring and the HEX, which is extra delicate and very gentle on the iris. But we must remember that iris hooks or pupil expanders do not guarantee against iris prolapse, but they do ensure adequate pupil size for safe picoemulsification. Now, how do we identify the rigid pupil? Now, when we inject a little bit of BSS from the side port, the pupil expands momentarily, and that tells us that it's an elastic pupil. Whereas, let's see what happens over here. When we inject BSS over here, this pupil does not budge. So that means this is a rigid pupil. This is a very easy test on the table. Let's watch a surgery by my friend Neto Rosatelli from Brazil. He's a gifted surgeon.
1 second, we are not able to see your slides. It's Mohan.
Not able to see the slides.
Mohan, you take out your share slides.
I'm sorry.
Pardon?
Who is
Dr. Mohan? By mistake, Dr. Mohan has shared his slides, so he'll have to exit from that, and Dr. Suven will have to upload his slides.
So I thought my slides were shown.
No, Dr. Mohan Rajan.
No, I was not able to see the slides, so that's why
Can you please take off your stop sharing your slides, Dr.
Yeah,
Mohan?
I'll do that. I'm doing that.
Thank you, sir. Thank you.
I'm
Suven,
not
can
able
you
to see
please?
Shall I start again?
I'm not able.
No,
to
you start from here, Suven, because we are short of time. So please upload
Gaurav.
your slides, and you can start right now.
No, were none of my slides seen so far?
Yes, but we cannot go back. So you can start from the slide till
That's a shame.
reached. Yeah, because you have to keep seeing. You should be able to see your slides in your own system also.
Yeah, I was seeing my slides.
No, so can you please share your screen, Suven? Yes, now we have your screen.
Yeah, now go to full screen.
Go to
Can
full
I go
screen and you can go
briefly,
to your video, I
Gaurav?
think. Go straight
Gaurav,
to
can
your
I go
video,
back?
please. No. Go straight
Okay.
to your video, Suven. Thanks for bearing with us.
Okay. So let's watch this video from my friend, Dr. Neto Rosati from Brazil. You can inject a little bit of viscoelastic into the anterior chamber, and then a little bit viscoelastic under the pupil margins. Advance the BX pupil expander into the anterior chamber and tuck the alternate flanges under the pupil margin. And once you have tucked all the three flanges, you have a nice 5.5 millimeter expanded pupil, which allows you a safe capsular access and a safe phacoemulsification. The device does not come in your way while you're doing your phacoemulsification or when you do your cortical cleanup, and you can move the device around to get a good view all over the place so that you can complete the cortical cleanup very easily. And then again, the device does not pose a problem for IOL injection. It allows adequate space, and you can easily go under the IOL and remove that viscoelastic. Removal of the BX pupil expander is extremely easy, and you just need to then draw it out of the main incision or the side port, and you have a wonderful round pupil. Now, there are so many predisposing causes for IFIS, so no amount of history taking can prevent surprises. So not using iris hooks or pupil expanders is a gamble. 2011, Kasuchi and co-workers published this work where they suggested that for a pupil 7 millimeter or smaller, the risk of IFIS existed regardless of alpha antagonist treatment. Now, iris hooks do require multiple corneal incisions, which increase the risk of infection. The pupil is elevated to the limbal plane, which predisposes to iris trauma, and there is a tendency for over-retraction, and the space of the corners is an absolute waste. There is an argument that pupil expanders require additional skill, more skill than phaco. Well, that's not real. And iris hooks also do cause disfigured pupils and obnoxious marks on the iris. And this is for Dr. Rohit. In case your gamble doesn't pay off and you do have an intraoperative meiosis and you need to be bailed out, well, the BX pupil expander is always there to help you. So you need to just inject a little bit of viscoelastic under the over the capsular rim, and then advance that flange as you tuck it to the periphery, and you have instant confirmation that you have not engaged the capsular excess margin. And once you have the third flange in, you have excellent visibility, and you're again back to your comfort zone. Thank you very much for your kind attention.
Thanks a lot, Suven. That was a wonderful presentation, and we saw the videos very nicely, and you came across very well with your earlier, even though your 2 slides missed out in the beginning. Thank you so much. So we'll quickly go on to our second speaker. I'll invite Dr. Bharti, who is again with us online now. Dr. Bharti is going to talk about how he prefers to use the iris hooks to tackle such situations with IFIS.
Good evening, everyone. I'm Dr. Bharti from Delhi, and at the outset, I want to thank IRSI, Amar, Mahipal, Gaurav, and everyone who's organizing this wonderful meetings during this lockdown, where I definitely enjoy these meetings. And is the slide visible to all?
Yes, it's visible. Please go ahead, sir. Thank you.
Yeah. So I'll be talking about the iris hooks, and I have my worthy opponents who have their own opinion and they're master of their trade. So I cannot say that they are wrong, but I'll see what is best in everybody's hands. It does not require any special skills, extraordinary skills to perform cataract surgery in a small pupil where the iris is all floppy as well. Floppy iris syndrome, the normal incidence is about 0.5 to 2% without any reason, without any pharmacological or any other reason or disease. But on tamsulosin, 43 to 100% of patients will have floppy iris. And this consists of billowing of iris stroma in response to normal irrigation currents. The floppy iris tends to prolapse through the phaco and the side pot, and a progressive pupillary constriction during the surgical procedure. And this is with the systemic treatment with alpha-1A adrenergic receptors, antagonists like efizocin, doxazocin, terazosin, but out of all, tamsulosin is in particular seems to play a pivotal role in floppy iris syndrome. So it could be from mild to very severe, and it can cause trauma to iris, zonular dehiscence, vitreous loss, posterior capsule rupture, increased intraocular pressure in the post-op time, and also cystoid macular edema. And it is a potentially sight-threatening condition after cataract surgery if you have this during the surgery. The indications for iris hooks or iris refractors, as they're called, is uveitis, trauma, previous surgery, especially glaucoma surgery, old age, pseudo exfoliation where the pupil dilation is slightly difficult, diabetics. We all know that pupil dilation is not satisfactory, and most important of them all, the floppy iris syndrome. So history, we go back, they started in about 1996, but before that, Makul floated the idea. He had some metallic iris hooks, and then Gather designed the first hooks, and Chang started using these hooks in IFIS. And then further, couple of more scientists, they continue to evolve the technology and technique and the material. And current design of suture material with plastic sleeve was designed by Hickenbotham, and that's very, very significant that at this point in time what we're using is the current form of iris hooks. Now in IFIS, the iris hooks are very, very important because in fibrotic pupil, this can cause bleeding, sphincter tear, and permanent large pupil, which my friend Suven told. But in IFIS, pupil is elastic and goes back to its physiological size despite being maximally stretched. And this actually provides the best surgical exposure compared to any other method of IFIS. So this is actually, when we go forward, we can see that iris hooks you can put in a square configuration or a diamond configuration depending on where you are comfortable, and you have more than adequate exposure of the lens for removal of cataract in all these cases. And the most important fact today is that there has to be a subincisional positioning of one of the iris hooks so that there is no damage to the iris during the surgery. So the technique is a single port of 2 to 2.6 millimeter for the phaco, 1 to 2 side ports of 1 to 1.2 millimeter for the other hand, the maneuver, and 3 to 4 ports of iris hooks, which will be about 0.5 to 1 millimeter. And the important fact is that if you use 0.5 to 1 millimeter ports, it does not lead to any astigmatism. So even if you have 4 or 5 small ports, the possibility of any astigmatism developing because of iris hooks is not there. And this is a very important fact that despite that we have the same kind of keratometry, And the technique is there are 2 ways. Insert each hook can hold pupillary margin, and retract hook followed by opposite hook. And you can continue all around, or you can insert all the hooks, 4 or 5, hold the pupillary margin and retract all hooks one by one slowly, and increase the size of the pupil in 3 to 4 steps. So it depends where you are comfortable. And here I'll be showing a small video where this is a very rigid pupil with a hard cataract. In this particular case, it's very, very difficult to do a phacoemulsification without any device, though my friend Rohit can claim that he can do it, but I'm sure after finishing there'll be some iris chafing and damage to the iris in all these cases. So like this, you can start pulling on first hook and then put the second hook, and like that you can continue. And here I'll be using one hook in the subincisional area, and then keep on putting. And this is the end of the putting the fifth hook, which I find most rewarding. And as you can see, the pupillary dilatation is much bigger. And then you can just remove them very easily, just disengage and pull out. Disengage and pull out, there is absolutely no problem. This is at the end of the procedure, that you can just pull it out without any damage to the pupil, and the pupil is absolutely normal after that. And there are three methods. Otherwise, you can pull in and out from the main port, or pull out from the port of insertion, or cut and remove. So these are the advantages of iris hooks over any other device or without the devices, that these are least traumatizing. You can increase the size of pupil according to your demand. No dislocation behind the iris is possible, where it is very difficult to find them later. No change in technique during the surgery, like you don't need to do any visco injections or anything. No possibility of back plan, that okay, you have started and then you want, in the midst of the surgery, you want to put a iris hook.
Sir, I'll request you to summarize, please.
Yeah,
because we are running short of time.
Yeah. So this is the easiest insertion, removal, and surgeon's regular technique, and it is the cheapest, can be reused, and no expensive system. Thank you very much.
Thanks a lot, Dr. Bharti sir, for those wonderful tips with the iris hooks, and very valuable. And we'll quickly go on to our third one, Dr. Rohit Om Parkash, who is going to talk about no devices for managing patients with IFIS, and he'll give us tips on how we can do that. Dr. Rohit Om Parkash, you can please uplink your presentation, and immediately after he finishes, we'll have a panel discussion for 5-6 minutes. During that time, the viewers can all put in their votes for either Dr. Suven, Dr. Bharti, or Dr. Rohit, in whichever technique they believe in, or which is their favorite, and that will give us an idea of what is popular with you guys. And we are also getting a lot of questions, so please go ahead, sir.
Yeah, am I on? Is my screen fully visible?
Yes, yes, please go ahead.
I'll be presenting a non-dilating pupil without using any device. There is a 4.4 millimeter pupil in a 74-year-old man who is on tamsulosin for the last 14 years. The iris you will find is blue, which in all probability is more prone to IFIS. So, before going into it, let's understand what are the differentiating iris and pupillary features. Well, the maximum pupillary diameter is small in these patients. And what happens is that there is a dilator muscle region atrophy. Can I just minimize this? I cannot see this. Yeah, there's a thinned out iris atrophy in this region, subsequent to which what happens is that with the fluidics which are coming in, have access to the posterior aspect of the iris. When they have that access to the posterior aspect of the iris, a thinned out just billows. And this billowing can cause an iris touch. So this iris touch can cause a pupillary constriction in these patients. So this is one thing we have to bear in mind, that there are three differentiating features in patients on tamsulosin. There's a decreased pupillary diameter, number one, subsequent to which there is an increased predisposition to billowing and iris touch because of thinned out iris, and there can be an exaggerated response of pupillary constriction. Pearl number one, have a long anterior tunnel. What will that do? That will prevent iris from prolapsing. So that is the first pearl which you should use. Then you should use a calibrated side port incision, which will take care of fluid access to the side port excision. So when the fluid efflux will be there, the chamber will be unstable. You can find that there is not much of a fluid efflux from that area. When there is no, when the chamber is stable, what happens is, the most important point is that there is less of billowing. And where there is less of billowing, as you can see in this, the non-calibrated incision, the iris is coming out and the IFIS has been initiated. It is all because of the vicious cycle which sets in because of many things. So a calibrated side port incision wherein there is stable AC is a very important. Pharmacomydriasis with epinephrine. In this patient, because it's an advanced stage, the epinephrine is going to have a limited effect because of atrophy of the iris muscle. Viscomydriasis is also very important. Pour visco in the subincisional iris so that the iris flattens and dilates. You can use an Arshenov trisoft shell technique also, visco-dispersive, followed by visco-cohesive. Then comes the BSS. Well, all that you may do, you can still end up, if you overinflate, you can start with the IFIS process. Capsulorhexis through a microincision. You can go with the forceps beyond the capsulorhexis margin. The tip of the forceps should be as close to the plane of the flap as possible, inflate, and you can very well complete the rhexis without any issue. Don't overdo in the hydrodissection because you can end up with an iris prolapse. Another important thing is the fluidics. You should know what the fluidics you have to use. They should be high IOP. The aspiration and the vacuum should be on the lower side. Continuous irrigation has to be off. Irrigation is off. There is no iris coming with it. The pressure in the anterior chamber is decreased. If you don't do this, then what happens is, then you create a situation, irrigation on, everything comes along with, and IFIS is initiated. So friends, you should know all these pearls which are associated with this in these patients. Emulsification of nucleus. Well, if you have to do emulsification in this hard cataract, you have to hold it in a deeper plane with guided vacuum. Separate the nuclear pieces. Don't do a horizontal, full horizontal chop. Divide the nuclear pieces into small pieces. Separate them fully. Mark my word, separate them fully and keep them there so that there is less excess of fluid to the posterior aspect of iris, so that there is less of billowing and everything which causes IFIS is stopped. Stable AC with less excess of fluid. Now comes the nuclear emulsification. Bring the nucleus piece into the plane of anterior capsule. See where the phacoprobe is. Keep social distance. Keep it in the proximal part. If you will keep a social distance in the proximal part, what is from the iris will not emulsify. At the same time, what is going to happen? The visco will also not get aspirated, which in this case is a visco-dispersive. Irrigation aspiration. Pearl number 1, retract the sleeve as much as you can so that there are two planes of irrigation and aspiration. See how I'm taking the shield of the anterior capsule to go deep. Now see the vacuum, low vacuum, hold it and bring it to the center. Low vacuum, hold it, bring it to the center. So there is no problem whatsoever. So bimanual irrigation aspiration can also be used in such situations. Next slide.
I'll request you to summarize as well.
Trifles make perfection. Perfection is no, you can see at the start and the end of the surgery, it's practically the same. Dr. Suven was saying that at 7 millimeter, you may end up with IFIS. Dear friends, you should know the technique. You should respect tissues so that the tissues should respect you, because there are potential difficulties and potential drawbacks which are involved with the mid-dilated post-operating causes, which can cause dysphotopsia, glare, and halos. Well, there are very few indications in my patients where I use these devices, wherein the pupil size is less than 4.5 millimeter. There is zonulopathy, and ACD is less than 2.75 millimeter. I think, Doc, my dear friends should not be blindfolded. They should take this blindfold off from their eyes and put masks on their, nose and on their mouth. Because if you respect tissues in the right way, you will be able to get through in most of the cases, and with your proper indications, you will be able to use the devices which Suven and Dr. Bharti has said. Thank you very much for your attention.
Thanks, Dr.
Can you stop the slideshow, please?
Yeah, I'm doing that, sir.
Rohit for those wonderful tips. So we've had excellent presentations from all the three presenters, and I'm sure our audience is all convinced about all three techniques. So we have a quick question for our panelists and for our presenters as well. Very short. The question is that how will you pre-medicate your patients if you're expecting an IFS? For example, a patient who's on tamsulosin. Are there any things that you can do prior to surgery which will prevent IFS?
Yeah.
Dr. Keiki, you'll have to. Dr. Rohit, can you take off your presentation? Yes. Dr. Keiki, sir, would you like to answer this question? Can you switch on your mic, please? Dr. Keiki, mic is off, I think. We can't hear you, sir. Yes.
Okay, now it's on. Okay.
Yes.
No, what I tend to do is to use mitricane inside the eye. Basically, that causes the pupil to remain much more stable than otherwise. And at the same time, try not to be careful that we do not use excessive viscoelastic inside the eye. These two are normally more than adequate. But one thing is certain, there will come a time when some of these IFIS patients will require to use of hooks. But that you can take a judgment depending on how hard your cataract is. If your cataract is not too hard, just simple mitricane inside the eye is adequate.
Yeah.
Thanks,
Yeah.
Dr. Mohan. Would you
Yeah.
like to comment on this? Whether any pre-medication you would like to use? Dr. Keiki has
No,
already
I
given
will
some nice
not
tips.
use any pre-medication. The atropine doesn't work in these patients. Stopping the Urimax also doesn't work. In fact, it can produce urinary retention for these patients. It's actually dangerous. So it doesn't work because this drug is there in the blood for more than a year. So it's a long-acting drug. So that's the reason why the iris dilator muscle is paralyzed because of that. So that is the reason why you have this problem. The biggest problem in phacoemulsification is not the subluxatory cataract or hard cataract. It's a small pupil. Please understand. Right in the beginning, I liked all the three talks.
I think
Yeah.
we've lost Dr. Mohan Rajan's this thing.
Yeah.
Can I pull in Dr. Mahipal, sir, please? Dr. Mahipal, would you like to comment?
Yeah, Gaurav, what I'll wish to say is that there are a couple of things that you have to do. First thing is that you have to assess the amount of pupillary dilatation right in the OPD. So nowadays we write in our OT list that this patient is on Urimax, and I do start the patient on atropine 3 days prior to the surgery. I do not stop tamsulosin, as Mohan rightly said. Stopping tamsulosin can actually give you urinary retention, but I do start them on atropine. And these are the patients that we are actually prepared that we might do it under a block. So I think the tip of Dr. Rohit Om Parkash is very, very sound, in which he's saying that we rarely take into account the side port incision. And if you have, I've seen his video of side port incision, where if he says that the side port incision is small, there is a lot of fluid coming out and the billowing does not happen. Now, there are a couple of questions. I personally would prefer a Malugan ring as compared to Suven's ring or an iris retractor. The iris retractor has obviously the advantage of being used again, but the disadvantage is that it tears the sphincter at that particular point, and that could be. So everybody has their own techniques. The idea is to get a better view and to keep the iris from coming into the iris into the phaco probe. So there are a couple of questions that have come. So when they have asked specifically that the dilatation that you get with your the Bhattacharjee ring is much less than you can achieve with an iris retractor. Any comments on that?
Yes.
And what is your cutoff when you would want to put a BX? Would you want to put it in all the cases or below a particular size?
Okay, the first question first. So the size of the expanded pupil. Now, if you analyze very carefully with the current fluidics that we have, it's not that the expansion that we require. What we require is the security that the pupil will not come down below a certain level. Any averagely skilled cataract surgeon, a phaco surgeon, if I tell him that, yes, I'm going to give you a 5.5 pupil, and that's not going to come down any more than this, he's happy doing a surgery on that. So the BHEX gives you a 5.5 millimeter pupil, which is adequate. If you have a hard cataract, you just chop it into smaller pieces, and that works well. So we've done very hard cataracts with the 5.5. And the advantage of having a 5.5 is that it does not stretch the pupil and disfigure the pupil or cause any tears. Now, if you talk about the threshold where I would like to use a device, well, yes, I'm prepared every time. So about anything less than 4 millimeters is where I would definitely use a device. And of course, if I have intraoperative in any stage, I would choose to use a device.
And Gaurav, there are a couple of comments on Omitria. So there are these are drugs that you can use during the surgery or just before that. So Omitria is not available commercially in India. That actually has a combination of ketorolac with a dilator, while phenocaine is likely to be available. You can it's still in the process of approval. So that has phenylephrine, it has lignocaine, and it has tropicamide.
Tropicamide.
That's a combination of phenocaine. So these are two medicines that can be used intraoperatively. They are preservative free. Ometria overseas, and it cost about $300-400. I think it's very, very expensive to have a vial of Ometria. So they make more money out of selling one Ometria than the entire surgery. So these were a couple of questions.
So there was another question, quick one, that Dr. Rohit Om Parkash, do you ever need to use any of the devices? Is there a situation where you have to fall back in spite of all these precautions that you take?
Definitely. As I told, wherever there is, can you hear me? Yeah.
Yeah.
Yes.
Yeah, wherever the pupillary size is less than 4.4 or 4.5, and if there is some associated zonulopathy, as I said, and if the anterior chamber depth is less than 2.75, those are the conditions wherein I definitely use a device. Because at the end of the day, we no doubt want to have surgical skills. We definitely would like to use the help, the aids to our advantage. Wherever required, I don't hesitate.
And
thanks, Dr. Rohit. So I think we'll, yes, Dr. Mohan, quick one.
What instrument do you use for the side port?
Sorry?
What instrument do you use for the side port?
I use
the calibrated side port. Yeah.
I use a 25 gauge needle, which has an outer diameter of 500 microns. And to go along with it, I use a chopper, which has a diameter of 400 to 450 micron as far as the shaft is concerned, so that there is less fluid efflux to that region. I don't have any financial interest. It is freely available all across. And that is what the shaft of the diameter of the shaft of the chopper is.
Thanks, Dr. Rohit. And we'll quickly go on. I think we have a lot of votes there, and all the three processes have received votes as the speakers spoke. Yes, yes.
No, I just want to give a very important take-home message for all people here, is that when you have a dense cataract and a pupil who is about 6 millimeter or less, then straight away go in for a iris dilated device, either a BX or a Malugin ring or iris hook straight away. Because during the surgery, if your pupil is going to come down on you, it's going to make matters very, very difficult for you. And all the complications are related to the small pupil. Please understand this. I like Rohit Om Parkash technique, but it is only for high-end surgeons like him. I think in the first time itself, I think you're able to hear me, Gaurav?
Yes, yes.
Yeah, louder.
Yes, yes.
Yeah.
Thanks, Dr. Mohan. I think the message is clear.
Yeah, very clear. Yes. Okay.
The message is clear. I think all three techniques hold good, and we've received almost equal votes for all three procedures. And what Dr. Mohan said is very relevant, that for a beginner surgeon, it may be a good idea not to get into a situation with a small pupil intraoperatively and to plan the device they are comfortable with right in the beginning. And for the proficient surgeon, he may be able, with a very short surgical time, he may be able to use all these pearls which Dr. Rohit said, and still manage to operate without the need of devices. Let's quickly go on to our next situation. So I think here, all three people get excellent votes. Thank you so much, all three presenters, and we'll be joining you again at the end of the seminar for a panel discussion. We'll go on to our second situation, and we'll invite two of our other speakers, Dr. Haripriya, Arvind, and Dr. Anagha Heroor, who are going to tell us, I think Dr. Haripriya first, on why she prefers to use intracameral moxifloxacin or an antibiotic for all her surgeries, and she has a case to make for that. To prevent any kind of adverse events. Please go ahead, Dr. Haripriya, and welcome to the webinar.
Thank you, Dr. Gaurav. Is my screen visible?
Yes, please go ahead.
So I would always say intracameral antibiotics is a must for all cataract surgery. And why? The ESCRS study and Ophthalmic study is probably the only large randomized controlled trial which looked at this question. And as per their data, the two groups, the B and D groups, which received the intracameral antibiotics, had a significant lower rate of endophthalmitis. Following this study and availability of the drug in Europe, there were numerous other publications, including from different countries using cefuroxime, cefazolin, and moxifloxacin. In spite of it, there are some concerns regarding the efficacy of this drug and the safety. So we'll just go through the list of the different concerns one might have when using intracameral routinely in your practice. The first being the efficacy. Now, in June 2017, we published our series in ophthalmology of over 6 lakh surgeries, where about half the patients received intracameral and half did not receive intracameral moxifloxacin. The endophthalmitis rate reduced from 7 per 10,000 to 2 per 10,000 in this data series, which was data from our 10 hospitals of Arvind eye care system. The subsequent publication, we enlarged the series, again published middle of last year in JCRS. We looked at data from 2 million surgeries. And of these 20 lakh surgeries, about half of them again received intracameral and half did not receive intracameral antibiotics. What is evident is that again, the endophthalmitis rate reduced from 7 per 10,000 to 2 per 10,000 in the same way as the previous paper. And also interestingly, we saw the efficacy not just in SICs, but also in phaco. In phaco, it reduced by about 6-fold and about 3-fold in SICs. Now, having known its efficacy in uneventful surgery, we looked at our data from the same 2 million cohort regarding the outcomes in the eyes with the posterior capsule rupture, which as we know has the highest risk of endophthalmitis. So we had data from over 28,000 eyes. And again, interestingly, we were happy to note that even in these high-risk eyes, endophthalmitis rate reduced significantly when we used intracameral moxifloxacin. So this is again data from across Arvind eye care system over these last 9 years. So as you can see from 2011 to 2019, we introduced intracameral antibiotic between 2014 2015. Endophthalmitis rate, as you can see, has reduced significantly over these last 3-4 years. And 2019, it was about 1 per 10,000 surgeries. So this is enough evidence for us up to be convinced about the use of intracameral moxifloxacin prophylaxis routinely. Besides, we also found a very low culture positivity rate, and the outcome also was good amongst those who had endophthalmitis, pointing more in favor of probably a TAS-like picture who were treated with intravitreal antibiotic steroids. So the endophthalmitis rate was probably a little lower than that. The second concern could be issues with reconstitution, with concentration and contamination. So we found that we use the Oralab intracameral moxifloxacin, no financial interest. So it is ready to use. We don't need to have any dilution. It comes in 1 ml vials. We draw in about 0.1 ml on a tuberculin syringe, which has about 500 microgram of the drug, injected into the anterior chamber end of the surgery. So this probably removes the issue of the concerns regarding concentration and contamination issues. The next concern could be toxic effects. Now, this is quite relevant considering one recent paper we have seen. Now, as per the 2014 ACIOL survey, vancomycin was the most commonly used intracameral antibiotic. 50% of their respondents used intracameral moxifloxacin. In 2015, there was an important paper by Wirkin et al., who reported 11 eyes with hemorrhagic occlusive retinal vasculitis, which is basically a delayed immune reaction to vancomycin, which is extremely rare, but again, an extremely severe complication following use of intracameral vancomycin. And following this paper, the second paper in 2017, they had 36 eyes in their series. So following this, the ACRS and ACRS now have an alert regarding using intracameral vancomycin. Now with moxifloxacin, we looked at our own data and we found that there was no increase in corneal edema in the 2 groups which did and did not use intracameral moxifloxacin, and all the cases with the persistent edema were not because of the intracameral drug. The next factor could be, would moxifloxacin be effective against all the organisms? Again, looking at data from this 20 lakh series, we found that moxifloxacin was effective almost against all organisms, gram-positive and gram-negative. And again, the gram-negative, the culture negativity also had increased to about 80%. So we probably were treating more of endophthalmitis, which were sterile. The last concern could be the issue of cost. Again, we know that the intracameral options we have today in the country are very cost-effective, maybe 50 rupees per vial, which we can use for more than 4 to 5 patients. But also, we also looked at this more in detail in our 2016, the first paper we had published, where we saw that the cost of the moxifloxacin, which we actually used in that series, was offset by the cost of actually treating the external ophthalmitis, which we had in the time frame, and we did not use the moxifloxacin prophylaxis. So in conclusion, as you can see, there are many, many, many papers which are in favor of intracameral antibiotics, and the endophthalmitis rate is very low in many of these papers. If you look at the 2015 Edward Jackson Memorial Lecture paper by Anne Coleman, endophthalmitis rate in the IRIS registry was about 0.08. So it's about 8 per 10,000. And many US surgeons also would like to use the antibiotic, but because of the lack of availability, because the FDA does not allow data from the retrospective studies, they're now considering designing a prospective randomized control trial amongst the different ASCRS surgeons so that they can have the drug available in their country. However, in countries like India and many others, we don't have to worry because we do have the availability of ready-to-use intracameral antibiotics. So we are convinced that we need to always use intracameral antibiotics during cataract surgery. Thank you.
Thanks a lot for that, Dr. Haripriya. You can switch off your screen, please. And I'll invite our next speaker. And remember, for the audience, that the poll will be on. You can vote for whether you would like to give antibiotic intracameral or would you not want to give it. And it'll be on right till the end of the panel discussion. And you can put it in the comments section on the Swarnim login portal on the right side. So we have Dr. Anagha from Bombay, who is going to tell us that it's not always necessary to use in every patient intracameral moxifloxacin. Please go ahead, Dr. Anagha. We can see your screen nicely.
Yeah. Good evening, friends. Thank you, IRSI. And this is my humble attempt to present my case on intracameral antibiotics during cataract surgery is not always necessary. No financial interest. Yes, post-cataract surgery endophthalmitis is one of the most devastating complications that we can have. But fortunately for us, the incidence is extremely low. But yes, it can become a surgeon's nightmare and it needs top priority. But remember, before we even go into antibiotic prophylaxis, preventive aspects are very important, and antisepsis rather than only antibiotics should be our mantra. So we need to screen our patients for preoperative risk factors, not only the local risk factors, but also systemic risk factors, which can make them more prone to endophthalmitis. Even before the concept of intracameral antibiotics came into picture, the topical 5% povidone iodine was being used, and it has been shown that bacterial colonies can be reduced by 91%, and the risk of endophthalmitis with just povidone iodine alone can be reduced from 0.24 to 0.06%. Now, coming to antibiotic prophylaxis, all of us are already using topical preoperative antibiotics, and intracameral antibiotics like vancomycin, cefuroxime, and moxifloxacin are being used. However, this unpublished Indian survey shows that among ophthalmologists in India, almost 75% use moxifloxacin. Now, if you see the preoperative topical antibiotics, 90% of us use it, 94% of us use post-operative topical antibiotics, and only 40% use intracameral antibiotics. If you see the penetration pharmacokinetics of topically administered moxifloxacin, if it has been used every 2 hourly just before the surgery, you can see that the aqueous concentrations of moxifloxacin would reach an MIC for 90% of isolates, and in the vitreous, an MIC for 50% of the isolates, which is quite significant. Now, how long does the effect of the intracameral injection last? Now, if you see this graph, only in the initial few hours, the effect of the intracameral injection would remain in the anterior chamber, but it would decline very, very rapidly. However, you can see this orange line where the effect of the topical antibiotics remains in the anterior chamber for a lot longer period, and this would cover the risk of contamination through unsealed clear corneal wounds, which would last for many days. So this was a very important study where they evaluated intracameral cefuroxime as a prophylaxis against endophthalmitis. And it showed that there is no strong evidence to support the use of intracameral cefuroxime to reduce the rate of endophthalmitis. The ESCRS study has already been mentioned by Mann, and it showed that there was a 5-fold reduction in the of endophthalmitis. However, it also showed that the presence of surgical complications increase the risk of endophthalmitis by 5-fold. So these are the patients who need our greater attention. It also had certain concerns. The control group had a rate of endophthalmitis which was 0.34%, which was much higher than in the other studies, probably because some patients in this group did not receive any antibiotic until the first day after the surgery. Also, after the injection was given, the reduced rate of 0.07% was almost similar to the rates in the US, where only use of topical antibiotics pre-op and post-op was used. Now, if you see the Mayo Clinic Foundation rates, where no intracameral injection was used and only topical antibiotics were used, the rate was much lower, just 0.02%, which was probably significantly better than the ESCRS rate with intracameral cefuroxime. Now, this was a list of reasons why ophthalmologists there did not want to use intracamerals. Some of them thought there was no need, there was no protocol, and they were concerned about adverse events. There was no approved commercial preparation. And yes, they were apprehensive about the contamination risk during preparation. Like, for example, the use of Vigamox there. This was advocated by Dr. Steve Archinoff. However, we all know that when you want to dilute or aspirate, there is a greater risk of contamination. So yet there is no US FDA approval, and these are all off-label uses. The bad news is moxifloxacin resistance is on the rise, especially for coagulase negative staph, 60% over the last 6 years. Susceptibility rates have decreased from 77 to 43% since 2004. And we all know that widespread and indiscriminate use can increase resistance very significantly. When cefuroxime was used, it had disadvantages that needed to be compounded, and there were dilutional dosing errors and severe adverse effects, not only with higher doses, but also with the routine doses, with significant evidence of TAS and retinal complications. Now, when intracameral vancomycin was used, again, it needed to be prepared. And like ma'am said, hemorrhagic occlusive retinal vasculitis was seen, and we are now seeing vancomycin resistant Staph aureus. So friends, already we have a very low incidence of endophthalmitis. In order to reduce severe visual loss from endophthalmitis in one patient, while avoiding ocular toxic effects in number of others, intracameral antibiotics must be mixed correctly 2,700 times, which I think is a bit of an overkill. So in my opinion, we need to have realistic indications. I'm not saying that we should not use intracamerals, but let it be restricted to high-risk patients like PCRs, leaky wounds, prolonged and difficult surgeries, one-eyed patients, elderly and immunocompromised patients. Probably in the high volume settings like that was mentioned in all of these trials, it would be a good idea. However, in a case where you have an uneventful surgery in a single surgeon setting and with all the prophylaxis right in place, probably it would not warrant the use of intracamerals in each and every patient. So concerns remain in large volume multi-center trials like what Madam has said. There could be variability due to different surgeons and settings. Wide indiscriminate use could hasten resistance. And I feel anything that enters the eye is a potential source of TAS or infection. And what about those strains that are resistant, P. acnes and fungal? Would intracameral moxifloxacin act against them? No. What are the long-term effects on the corneal endothelium? Will intracameral injections obviate the need for postoperative antibiotics completely? And it should not give us a false sense of security. It is not a substitute for a good preoperative prophylaxis. To conclude, we need a multi-pronged approach. So we have proper prophylaxis, preoperative and postoperative topical antibiotics, but let intracameral antibiotics be restricted for the high-risk cases that we see. And before we expose all millions of our surgeries and patients to intracameral use, I think we need more research to know about the safety and effectiveness. Thank you so much for your kind attention.
Thanks, Dr. Anagha, for that nice presentation. And I think both of you have made your point so well. It's going to be very tough for our, people on the audience. Anyway, I'll quickly ask first, take a poll of our panelists. Dr. Keiki, sir, do you use intracameral antibiotics, and do you use them for all your patients or for select indications?
No, I use it as a routine for all my patients, but I entirely agree with Dr. Heroor that you should not have a false sense of security, and the use of preoperative antibiotics and povidone iodine is, I think, mandatory, because that is what really protects you more than anything else. But
what preparation do you use, sir?
Sorry?
What preparation do you use?
I just use full strength Vigamox.
Moxifloxacin, is it Vigamox?
Yeah.
And you don't dilute it, and what quantity do you use? Because there are several questions about dilution.
I don't dilute it at all. And when we did an analysis to find out as to whether the cornea is affected by utilizing more or less, it really doesn't make a difference. We just squat a little inside.
Dr. Mohan Rajan, sir, would you like to quickly chip in?
And I use intracameral moxifloxacin. I use the Minims, which is made by a company called Centis. There's also another company called Sunbase, which is making these Minims. And I also use the Urimax, which is made by Arvind Group. And I use this routinely. Okay.
For all patients?
Yeah, all my patients, whether
And
it's
any dilution, sir? Any dilution?
straight away 0.1 ml, straight away I inject it into, I make sure I go underneath the anterior capsule and inject it into the bag. So I put an air bubble go underneath. So that's the way I do. I do it slightly differently, but doesn't undermine the fact that you should all follow all the pre-operative and intraoperative protocols of asepsis. That is very, very important. Okay. As Anagha Heroor rightly said, don't think that intracameral antibiotic alone will save you. That is not the thing. You should have proper pre-operative, proper intraoperative, proper post-operative protocols in place. Okay, and then you use your intracameral. And more so when you have a PCR, please understand, if people don't use it on a regular basis, when you have a PCR, please use intracameral moxifloxacin. Okay, because
thank you so much, sir. We'll go on to Dr. Mahipal.
Yeah.
Dr. Mahipal, sir, would you like to add anything to what we've had from Dr. Keiki and Dr. Mohan?
Yeah, there are a couple of things. I think the first answer is that yes, we use routinely, and things that I'll wish to add is that I think the pharma companies and us should actually make it an on-label use rather than an off-label use, because that is the only thing which is there. So companies are not specifically coming out now; they are coming out with injections, etc., as preloaded syringes. So I think that will be better that if it is put as an on-label use. I don't know why there is. Some trials are required or whatever is required, that should be made as a non-label use. Obviously, there is nothing that replaces a pre-operative good and a betadine prep, etc. The logic behind giving an intracameral is like any surgeon, you have a GI surgery or you have anything, they give a bolus or a shot of all antibiotic, metronidazole, etc. So that at that particular time, the cidal concentration within the bag is very high of that antibiotic. So there could be resistance, that is agreed, but the concentration that you achieve for those couple of hours is a highly cidal concentration. So it kills all the bacteria which are sensitive to this antibiotic. Yes, there could be resistance, that is something different. But when you are having multi-centers, multi-location or multi-surgeons, I think it becomes all the more reason, because the kind of the steps that each surgeon takes, the amount of wash they do, or how do they change gloves, etc. That's not that you try to standardize it, but then everybody has his or her own fancies. So I think under where there are large number of cases that are being done, I think it has become almost a standard of care. But I think there is, if you have good preps and you do good autoclave, etc., and you have the proper equipment sterilization, I think you can get away with a very, very low incidence of endophthalmitis.
Thank you, sir. I have a question for Dr. Haripriya. We are getting a lot of questions. I'll put on two questions to you. One is that, is there any risk of vasculitis with moxifloxacin intracamerally? I know the answer, but I'll allow you to answer that. Second is that why can you use any antibiotics in the infusion fluid, which means in the BSS, do you need to put, or it is not required? And if yes, then what should you do? And third question is that how do you dilute the Oromox and how do you load it? So very briefly and quickly, ma'am, if you can answer these three questions.
Yeah, so there is no risk of vasculitis. That is one. Second, there is no point in using it in the bottle. So I think you're only increasing the risk of contamination of your BSS or your fluid. So you can use it in the eye directly because you have a high concentration and this is more effective. And the third question is, you spoke about was, say that again, the third.
The choice of antibiotic, like, and how you load it from the vial.
You don't need any dilution. You need it straight. You just have to draw in about 0.1 ml from the vial and use it straight in the eye, end of surgery, after you formed your sideboard.
The concentration is the same as an eye drop. That's what they're asking.
Yes.
Haripriya?
Yes. Thank you, sir. Anything else, Dr. Haripriya? And otherwise, we'll go on to the poll.
I add one more point. Just that about the resistance is one concern which we have. But most of these studies on resistance talk about serum based on serum concentration. Whereas aqueous concentration, because we give it in the anterior chamber, even if you give a small dose, it's a very tiny dose compared to the topical dose. But the concentration is so high, it becomes very effective. So that is why it is so effective when we use it intracamerally.
Wonderful. Yes, Dr. Anagha, would you like to chip in with the last final word?
Do you autoclave the vial?
We do autoclave the vial because we use it on the table, because we use it for more than one patient. So does
that cause any degradation in the antibiotic after autoclave?
No, it does not. So it can actually go through 2 autoclaves. We don't do it more than once, but it can. The oral lab has done the testing and all that. It does not undergo any degradation. So you can use it. And the other point also is
Wonderful.
that while topical antibiotics we all use routinely as standard of care, I think there is no publication which has showed the efficacy of using topical antibiotics. I mean, in countries like India, it makes sense, but there is no evidence actually there which talks about the efficacy. All of them talk about the powder and iodine, but topical antibiotic prophylaxis, we are still not very clear about any evidence-based.
Dr. Haripriya, are you using preoperative antibiotic drops in Arvind eye care system?
We do. Like I said, we all do. So we do use, and we also help. We use it for any other adnexal lid and ocular adnexa kind of diseases.
There's another question, Dr. Haripriya, which says that if you put right at the end of the surgery, like people, Dr. Titial I have seen, and there's a question here, if you put 2-3 drops right at the end of the surgery, not intracamerally, is the absorption at that particular level much lower as compared to if you put it intracamerally?
Yes, sir. I would think drops is still not good enough. Intracamerally, the dose is much higher. And also, we always think resistance because of intracameral use, but there's a much higher chance of resistance with topical use. So we do use iodine. Topically, end of surgery, we used 1 drop of iodine, but intracamerally, we use moxifloxacin.
Do you use post-operatively the topical antibiotics as well, Haripriya?
Yes, so the same bottle which the patient buys pre-op, until the bottle lasts for about a week, they would use it twice a day.
Thank you, ma'am, and thank you, Dr. Anagha. Both of you made an excellent point in your presentations, and I think the take-home message is very clear. I won't have to summarize it. To finish off, I'll just add that at the end of surgery, what I use intracameral moxifloxacin for all my patients as well. I also kind of hydrate the stroma with a little bit of this moxifloxacin and put like 0.1 ml into the wound, because that protects the wound as well. And I think that the maximum concentration at the wound is what you need, besides putting like a 0.1 into the chamber. I don't know if that is great, but we don't have much time for discussion. So thank you so much for joining us. And we are now going on to the next question. So we've received votes are, phenomenal. Everybody has voted. Everybody's voted for intracameral moxifloxacin use for sure. And yes, people have said that I would use it routinely, and some have said that we will use it in all our high-risk patients. So the message is clear that it has a very, very strong role. And with that, we'll go on to our next. Sir, Dr. Mahipal wants to add something? Yes.
I also use it for my LRIs, because you already have moxifloxacin on the table and you have the LRIs that you are doing on femto. So I just put a drop after doing the intracameral use. I just go into the incision and put a drop of moxifloxacin.
Put a drop. Wonderful tips, sir. Wonderful.
I had 1 or 2 cases of infiltrates in my LRIs.
You're absolutely right. I've had that too, and that's a great tip for LRIs for femto surgeons. We can put a small droplet into the LRI. Thank you so much, Dr. Haripriya and Dr. Anagha. We'll request you to stay up with us till the end of the discussion. And for now, we'll invite our 3 new speakers. We have a situation here for the audience now where we have an intraoperative PC rent. And now we don't have adequate capsular support, so we cannot put in any kind of IOL in the bag. And we don't have support of the Rexis as well. So what kind of lens are we going to put now? And we have 3 very distinguished speakers. We'll start with Dr. Ashu Agarwal, who's going to tell us about how we can still use an ACIOL and get away in certain situations. It's still a great idea to use an ACIOL with the correct safeguards. Dr. Ashu, you can upload your presentation, please.
Thanks, Gaurav. Can you hear me?
Yes, we can hear you. And can you quickly uplink your presentation?
Yeah. Okay.
Welcome, Dr. Ashu Agarwal from Delhi.
Great. Thank you, Gaurav and IRSA for this opportunity. So I'll be talking about the option of anti-chamber IOL once we have inadequate posterior capsule support. Of course, the usual options are ACIOL, scleral fixated lenses, which could be the traditional sutured ones, or the newer glued IOLs, and iris supported lenses. My job is to talk about ACIOLs, and ACIOLs came into the scene very early in the history of intraocular lenses, soon after Dr. Ridley's lens, and the first one was implanted by Barron in 1952. However, the earlier ACIOLs went into disrepute because of primarily poor design, the closed loop design, poor quality of manufacturing and polishing, and improper use. Basically, the sizing issues. What was done was one size would be fitted to all the eyes, which was very, very wrong, and which is probably one of the biggest cause for them going into disrepute. The so-called newer, it's been around for almost 4 decades now, Kelman multiflex design has overcome most of these flaws. It's an open loop design with flexible haptics and an anterior volt of 0.5 millimeters, which reduces pupil block and iris chaffing and uveitis. If implanted properly, the results are very good, and studies have shown that there is no significant progressive corneal endothelial cell loss with Kelman multiflex design. This is the design that we are very familiar with. And I'd like to make a statement here that it is not the proximity of the lens to the endothelium, rather the pseudophagodonesis that is responsible for endothelial cell loss. And to support this statement, as a cornea surgeon also—
Ashu, your presentation is not visible on screen. Full, yeah.
Sorry?
Are you on share slides?
Yeah, I've done that.
No.
Just a second.
Only your screen is not visible.
Okay, but I'd shared the slide. I'll just try again.
Have you opened your slides on PowerPoint, minimized it, then go to share screen and
Yeah, I did that, sir.
Share screen, yeah.
No, I did that.
Press share screen again.
I'll try again.
Yeah.
Is it there now?
Yeah, now go to full screen.
Yeah. So you want me to start?
You go on full screen and just skip the slides which you have completed already.
Okay, so as I said, ACIOL, these are the options. And the Kelman multiflex is a very good option, and that it is not the proximity of the lens to the endothelium, rather the pseudophagodonesis that is responsible for endothelial cell loss. And to support this is a picture of a patient 10 years ago with a clear corneal graft and ACIOL in place. So the options are inadequate capsule support, and of course the contraindications are unhealthy corneal endothelium, uveitis, absent or insufficient iris support, and pediatric eyes or eyes with shallow anterior chamber. So what are the advantages of ACIOL? It's a very relatively quick and relatively easy procedure to do, and in a difficult situation that you're faced with, it stabilizes the situation and can be done by most surgeons, in contrast to scleral glued or iris fixated, which have a bit of a learning curve. That ACIOL has a much shorter learning curve and it performs well. However, there's a note of caution. We should adhere to the proper technique and indications. We should ensure good anterior vitrectomy, and some critical issues are correct sizing, which can never be overemphasized, and correct orientation of the lens. And we should consider other options if the correct size is not available or other contraindications exist. For instance, in India, we usually, some manufacturers advertise 3 sizes, but we only get 1 size. And Alcon, for that matter, in the US markets about 5 to 6 sizes. So sizing is of critical importance here. The aim is to have a IOL in the anterior chamber which is well centered, properly sized, properly powered, and oriented, with the haptic resting the scleral spurt, with no iris tuck, and haptics away from iridectomies, with no vitreous in the AC or the wound. For sizing, we should take the horizontal white to white limbal diameter and add 1. And for orientation, this is the lens. This is the trailing haptic. The trailing haptic looks like the bottom half of a reverse Z. Z would be like this. There's a reverse Z. And of course, the optic haptic junction is just like any other PCIOL on the left side, and the knee is on the right side. Vaulting, if you ensure correct orientation, automatically the correct vaulting is there. They're vaulted 0.5 millimeters anteriorly. In surgical technique, it's pretty much everyone's familiar with it. I'd just like to highlight a few points about viscoelastic, which is something which I use, and it's my preference. I initially use a dispersive viscoelastic like HPMC or a chondroitin sulfate based like Viscoat, no financial interest. And then a cohesive viscoelastic is used to fill up the anterior chamber, something like sodium hyaluronate 1.4%. This is akin to the soft shell technique, where the dispersive coats the endothelium, protecting it, but cohesive keeps the AC well formed, and more importantly, it is very easy to wash out during irrigation aspiration and just comes out like a bolus. And very early on in my career, when I used to do this technique, this surgery, I realized that when I was trying to remove the viscoelastic by irrigation aspiration, the vitreous would get hydrated and would start coming out, and sometimes it would be pupillary capture, and it was a total mess. I realized when I use a sodium hyaluronate there as the bulk of the viscoelastic, it comes out as a bolus, and the surgery is much neater and cleaner. So I'll just go on to a video. So this is a side port. There are 2 videos, but I think I'll be only able to play one in the interest of time. This one was a secondary IOL implantation, so therefore the wound was reformed. A chondroitin sulfate, a viscoelastic was done, then a second chondroitin sulfate base is this is to coat, and then a sodium hyaluronate is being injected, which forms the bulk of the anterior chamber. And as I said, when removing it at the end of the surgery, it's very easy to come out. the sizing is done. The size is 11.5. We have a 12.5. Luckily, this size, the size was available for this. I'd like to, and this is the volt. It is volted anteriorly. And see the orientation, the bottom half of reverse Z. And go in, that little tip here, try to, when you enter, you try to go in as parallel to the iris so that you don't engage the pupil or the peripheral iris gets stuck with the haptic. This is an embedded video, so I can't control the speed. I'm sorry. I could have skipped most of this. So you go in you're going as horizontal as possible, then tuck the foot plate behind and the knee.
Ashu, I think the video has been well seen. Is there any slide after that?
Yeah, just one.
Yeah.
So this is the pre-operative picture. This is the post-operative picture, 1 week. I'll skip this one. So a few tips and tricks. We have to ensure correct sizing, which again, as I said, can never be overemphasized. There should be correct orientation, avoid iris tuck, appropriate location of iridectomy should be there. The haptics may rotate through them. Ensure adequate vitrectomy, which is very important, and the use of OVDs as the technique that I told you, just told you about. And in conclusion, these present-day ACIOLs perform well if we ensure compliance to basic principles discussed. It compares very well to scleral fixated IOLs and is easy to implant with a shorter learning curve and a good technique to have in one surgical armamentarium. Thank you for a patient hearing. Gaurav?
For some reason. Okay. Quickly go off your presentation and we'll request our next speaker. We are running a little behind schedule. I'll request all the speakers to please stick to their times and make your point quick. I'll invite Dr. Shreyas Ramamurthy from Coimbatore. He will be telling us about how he prefers to use iris supported IOLs. Shreyas, can you please uplink your presentation?
Good evening, everyone. Can I have the my video on, please? Not been allowed to start my video. If the
admin, please.
Admin, can you give me permission to start my video? Yeah, thank you. So while I go on to put on my presentation at the outset, I would like to thank IRSI and Dr. Gaurav Luthra for allowing me to talk in this platform. Thank you so much. I hope my slides are visible. So good evening, everyone, and I'll be talking about retropupillary iris fixation of IOL. And the three choices here, ACIOL, iris fixation with SFIOL. I don't see any reason why an anterior segment surgeon should not opt for iris fixation as their primary choice because of the numerous advantages. One, it can be done under topical anesthesia with the situation given. You have an unexpected capsular loss, unexpected subluxation, and you don't even have to convert into a peribulbar surgery. It results in a deep anterior chamber. It's very gentle on the corneal endothelium. It is well away from it, unlike an anterior chamber IOL. There are no sizing issues, unlike in ACIOL or SFIOL, where in ACIOL especially, it's very unreasonable to expect to have a large library of lenses based on your white to white. It has a very, very quick and short learning curve, almost as easy as putting the lens in the bag. It can be used when the visibility is very poor, even in open sky procedures. And most importantly, minimum manipulation of vitreous. This is the lens of choice for an anterior segment surgeon. All anterior segment surgeons, including myself, are guilty of doing a glued IOL or an SFIOL without doing a complete vitrectomy. The kind of instrumentation that we use, the kind of forceps, the needles, all dangling inside the vitreous cavity, moving inside the vitreous cavity without doing a complete vitrectomy can definitely be dangerous for the eye. Let me move on to a couple of quick videos where I'll show you the ease of doing the surgery. You can either use a clear corneal incision or a scleral incision. In this case, since this was a planned iris clip lens, I'm removing this entire subluxated lens in toto. A complete anterior vitrectomy is a must, and then this IOL is then pushed in place. A scleral incision is also useful because it enables us to reduce the amount of astigmatism as this lens goes through a 4.5 to 5 millimeter incision. And as you can see here, each haptic can then be tucked behind and then be enclavated. Once it's enclavated, a viscoelastic wash is done and the surgery is over. just takes a couple of minutes, and the entire procedure is so exceedingly easy with elegant results. This is a more difficult situation where this is an aphakic eye and it's a decompensated cornea. The visibility, as you can see, is extremely poor. Doing an SFIOL in this condition would be very difficult. And at the same time, I would not do a ACIOL because I'm going to do a combination with a DSEC procedure. And in these kind of situations, an iris clip lens is a godsend. You can see the visibility is quite poor. I do a complete anterior vitrectomy, enlarge the incision to about 4.5 to 5 millimeter, and then push in the iris clip lens in place. Once it's pushed in place, it's oriented along the right axis along 3 and 9 if you're using a superior incision. And then each foot plate is taken behind the iris and is tucked in place and is enclavated, as you can see here. No special instrumentation is required. Just a simple haptic normal forceps is sufficient. You can push in the DSEC lenticule subsequently and inject the air. And I would like to show here that an iris clip lens is extremely stable. Despite increasing the pressure like we are doing in this particular case, the iris clip lens remains absolutely stable, allowing you to attach the lenticule without any difficulty whatsoever. Even in cases where there is loss of iris tissue, you can easily do a small pupilloplasty, as in this case, and then do an iris clip lens and give excellent results. What about the long-term results of iris clip lenses? It's one of the studies published almost 5 years back, which has looked at 320 eyes, 141 post-trauma, 122 in complicated cataract surgeries, and 57 in combination with PK, all variety of difficult situations. And they showed that there was just 3 disenclavations, all which happens in the early phases, learning curve. But once you've learned to enclavate the lens properly, it's extremely easy, doesn't happen. Only 1 patient of retinal detachment out of so many complicated cases. No cases of prolonged uveitis. Just 5 cases had iridodonesis, which again can happen in these prolonged aphakic eyes, and no significant drop in endothelial count, most importantly. I see no reason why, in the absence of adequate capsular support, that retropupillary iris fixation is an excellent option. The only reason we may not be using it almost entirely today is probably because prominent surgeons like Amar Agarwal have not made an option like iris fixated lens as sexy as you would like it to be in ophthalmology. But practically, this is definitely the lens of choice in almost every single situation. Thank you so much for your kind attention.
Thanks a lot, Shreyas, for that wonderful presentation. And before we barrage you with questions, I'll invite Dr. Ritika to make her case for glued IOL. And she's going to show why she prefers glued IOLs. And then we'll have a poll for the audience for what they prefer between the 3 techniques for their own search, for their own situations.
Is my screen visible?
Yes, Dr. Ritika, you can go into slideshow, please.
Yeah, is it visible?
Yes, perfect. Thank you. Go ahead.
Okay. Good evening. I'd like to thank IRSI for this platform. And now I'll be talking about my preferred IOL option in cases where you're faced with a PCR while doing a cataract. Now, as cataract surgeons, we all love to implant an IOL in the place where the physiological lens sits, which is the posterior chamber. Though we've heard that the anterior chamber and the iris are suitable alternatives, over the last few years, we've really seen transscleral IOL fixation becoming more and more popular. The problems with the sutured version of the scleral fixated IOLs have been done away with. You now have a surgery with the glued IOL, which is relatively easier as compared to the sutured version. Suture-induced inflammation, degradation, and late onset IOL subluxation due to suture-related issues are no longer there. So really, the use of glued IOL comes to us from a conviction of using it since 2011, and I'll be sharing our experience. This surgery really has 3 basic components. The first component is the use of hydrophobic acrylic lens, which is a multi-piece lens, which is normally there in our inventory. This has 3 main advantages. First, of course, it's there in your inventory. Second is that you can put this through a small incision. This is a foldable IOL. You can inject it through the incision that you made for phaco. And most of the times we are really doing a phaco surgery and we don't want to extend or create a scleral tunnel. The third advantage is that you, with these options, give the patient the advanced optic designs, be it the aspheric optic, and in fact, you can extend it even to the multifocality and use it even in the aniridia IOLs. So with the fibrin glue, again, this basically just gives you a quick healing and almost sutureless surgery, much akin to a phacoemulsification. Just a quick recap of the technique. Two partial thickness sterile flaps, 180 degrees apart, and you can insert the IOL either through either directly, but preferably through an injector. The haptics are then grasped through the MST forceps, which has come in through the sclerotomy. Initially, in a few cases, we did break the haptic, but that was part of the learning curve. Now, with so much experience, we know that we have to hold the tip of the haptic. And if you're doing that, chances of breaking the haptic are near zero. Unique thing about the glued IOL is the chariot sprocket that you create with a needle. And once these haptics are tucked in here, it doesn't budge. The fibrosis around this really makes the movement, which is longitudinal or transverse, negligible. What this translates into the very secure IOL in the posterior chamber with almost nil pseudophacodonesis. This gives you very little chances of CME inflammation and gives you a very stable and centered IOL. You've had various modifications described by various surgeons. I'll just show you a short video clip. This is a patient taken in 4 phaco. You see we are using the same clear corneal incision. The injector, again, a foldable IOL. This is the second haptic, which is being moved in. The tip of the haptic, like I said, not in the middle, in the tip, externalized. And then you simply tuck it in into the tunnels which have been created with the needle. You see the surgery looks very clean. You simply dry up the sclerotomy sites and seal them with fibrin glue. And the patient looks almost like that of a routine phacoemulsification case the next day. Another advantage is that sometimes in a deficient PC, we put in a 3-piece IOL. You can actually glue the IOL if this has decentered or dislocated the same IOL back. Intraoperatively and postoperatively, there are various listed complications, but with as you learn the technique, the chances of damaging the iris, creating hyphema and vitreous hemorrhage are much less. Postoperatively, with a well-secured IOL, there are very little chances of IOL dislocation. However, you may see some vitreous hemorrhage and CME. What really lends our conviction to this IOL technique is the follow-up we have of nearly 1,000 eyes. We've been using this technique since 2011, mostly in cases with aphakia or subluxation. 80% of our cases have achieved visual acuity better than 6/12, and the spherical equivalent is much less than if you would have to enlarge the incision in an unpredictable manner. These are some of the cases. You see here an anterior chamber, a 3-piece IOL placed in the anterior chamber causing multiple problems has just been repositioned into the posterior chamber. This case almost looks like a routine phacoemulsification, and in fact, the fellow, when he saw the post-op on week 1, had just written PC IOL in situ, because that is how clear the lens looks and how physiological it looks. The complications in 1,000 cases plus, this is the list of complications we've had. Significant complication has only been vitreous hemorrhage, but see that the rate is less than about, it's about 1.2%. CME, which is significantly damaging to the vision, is seen only in 52 eyes of the 1,000 eyes. That really is tribute to the fact that this lens is very secure and causing minimal inflammation. As regards the ACIOL and the iris claw option, I think a beautiful line said by a surgeon was, I've never met an ACIOL in my life that I've liked in the long term. So relationship with an ACIOL cannot last more than a decade. And with increasing longevity, you don't want to see your patient even after a decade like this. This is what we had to do to the patient, glue the IOL and then do a keratoplasty. Literature now supports glued IOL with tremendous follow-up. This is a 2011 paper showing that now the learning curve is nearly negligible, with many people giving many talks on it and having a lot of knowledge. And this is the 2011 paper. 2019 and 20, now we have more than 5 years follow-up saying that this lens doesn't really tilt or move. As regards the iris fixated IOL, there's a very large study done at the Arvind eye hospitals, and what they show is that there is a high degree of complications such as iritis, corneal edema, SK and hyphema, up to the tune of 30% in these cases. And there is a risk of damaging the iris in terms of ovalization and a possibility of a complication when you're doing a vitreoretinal surgery later if required. This study actually compares the retropupillary iris claw versus the scleral fixated IOL. And what they saw was that at 1 month, vision was much better with a glued IOL. That is because the iritis and the inflammation was much less. At 1 year, the vision seemed to match. But remember, the patient has come to you for a routine phacoemulsification and needs to get rehabilitated and back to work latest by a month. So why would you want to give him a technique which causes inflammation which lasts much longer, sometimes up to a year? Spherical equivalent will be much less because you're putting the lens in a physiological position and using a tiny incision.
Ritika, can you summarize, please? Yeah.
This is the meta-analysis which shows that the raised IOP, CME, and decentration risk is lesser with a glued IOL as compared to that of the retrofixation. All in all, in our hands, we feel that with more than 1,000 cases and more than nearly a decade of follow-up, the glued IOL is a technique which can easily be mastered. It does not take very long. It gives you the ability to use an IOL which is already there in your inventory and gives you an outcome much like a routine phacoemulsification. Thank you for your attention.
You'll have to unmute, sir.
Yeah, Gaurav?
Gaurav, unmute, or should I? Gaurav, you are muted.
So I'm has 30 seconds to counter what Ritika has torn apart for both of you, and then I'll give 30 seconds to Ashu. But quick ones. Shreyas, can you give 2 quick points to counter how Dr. Ritika, said that iris supported is not good at all?
So studies which Ritika quoted, she quoted a study with 28 eyes. I have shown you a study with 512 eyes with excellent results. With just one retinal detachment among the 512 complicated eyes. And obviously, when you're comparing iris clip and SFIOL, if you're looking at visual recovery and the speed of visual recovery, which was what was spoken about in the second paper, as such, if you look at the technique and the surgery itself, I don't see any reason why an iris clip should give you a more delayed visual recovery than an SFIOL. Yes, obviously, the primary surgery here itself would have been complicated, and that is why you're going in for a secondary SFIOL. And probably the issues related to corneal edema, high femurs, all these issues are related to the primary surgery itself and not due to the choice of lens. Again, as I said, there is a significant amount of manipulation in the anterior mid-vitreous cavity with SFIOL, which in a normal anterior segment surgeon who is comfortable working in the plane of the iris and in the sulcus will not be extremely comfortable with, or should not be ideally comfortable with, because we do not do a complete pars plana vitrectomy in these cases. In the hands of a retina surgeon, when there is an IOL drop, definitely SFIOL is the procedure of choice. But in a routine case, when you're faced with such a complication, in a case with topical anesthesia, when you're doing a cataract surgery, an iris clip lens is easily the way to go.
Thanks, Shreyas. You made your point. I'll request Ashu one quick point to say why Ritika said about ACIOL. She's not happy to do them, but be very quick because we have to go on. Yeah.
No. Yeah. Okay. You give me 30 seconds, right? So I would say that all the 3 techniques are good and have their own place. But however, when you talk of the learning curve, we are talking of disseminating this information. Some of the people sitting here are some of the finest surgeons in the country. But we're talking of an average guy sitting in his own clinic and in his own OT and trying to do it. So in terms of the learning curve, there's no doubt that ACIOL would be the simplest out of the other 2, number 1. Number 2, provided the right size is available. Shreyas, with your understanding of the cornea, do you really think that it's the proximity of the IOL to the endothelium that is causing the problem? It is the pseudophacodonesis. And if a well-planted, implanted ACIOL is there, which is well sized. Now, sizing is critical. I realize, and I mentioned in my presentation, if the size is not available, move on to something else. This is the visual recovery is perfect. It is a very stable lens. And if the sizing is right, there's no pseudophacodonesis. This lens lasts, believe me. But yes, the other 2 options also have their own place.
Thanks, Ashu. We'll take a quick poll from the panelists. Dr. Keiki, what's your favorite way of managing this?
At present, I'm on to a Yamane.
Yamane technique.
Future is Yamane, but I would like to quickly stress one thing. What Ashu said is right. Comments regarding the instability of an anterior suture, what should I call it, a Daljit Singh type of lens place is very different to the same lens being placed in behind the iris. It causes much less phacodonesis and CME rates are much lower. So Ashu is right in what he is saying.
Thanks. And Dr. Mohan Rajan, thank you so much, Keiki sir. Dr. Mohan Rajan, can you add anything to this very quickly? What's your favorite technique?
Fluid oil will be my choice in majority of the cases. I also use retro-iris fixated lenses as well. But however, in older patients, if the cornea is healthy, nothing wrong in using an ACIOL. Only the sizing of the IOL, as Ashu rightly said, and also making sure that there's no vitreous in the pupillary area or an anterior chamber. Don't forget to do a peripheral iridectomy. So these are the things that ACIOL can still be done for older patients.
And Dr. Mahipal sir, would you like to add to this quickly?
And steroid in the AC to make sure you don't have vitreous strands.
Yes,
that is what causes the
absolutely, absolutely, sir. Absolutely.
Wonderful tips, sir. Dr. Mahipal sir, anything you would like to add to this?
You put me in a dilemma because on one hand it's my doctor.
Sir, choose the easy way out. It's go for me. No, neither the daughter nor the son-in-law.
So Mahipal sir does love to do both iris fixated. Ashu, you're the only one who's going to get it from Mahipal sir. He just doesn't like ACIOLs anymore. You know, he'll either put an iris claw or he'll put a glued IOL.
Yeah. So obviously, the only one caveat is that yes, if you have good retinal surgeons with you, I think glued IOL is really a good choice. There are obviously anterior segment surgeons who may not be good at doing a glued IOL, but if you look at physiology, anatomy, the phacodonosis, etc., I think high-speed videography shows that the iris clip lens does have a lot of donosis that is there. So at least in center of sight, we prefer the glued IOL.
Sir, just one comment. Gaurav, just can I just make one comment?
Yes.
One thing I've learned from Dr. Mahipal is, जो होना table पे खत्म करके निकलो OT से.
Yeah.
Sir, उस समय at that point of time, for the average guy in the country, ACIOL would probably be the real advantage that you have.
So keeping an inventory of ACIOLs and iris claw lenses is mandatory now. I have a quick last.
Or somebody.
I can't afford it, sir.
There's one last quick question for Shreyas. Do you need a PI for retrofixated iris claw lenses, and what kind of forceps do you use? Can you quickly tell us so that we can go on to the next question then?
A PI definitely I would recommend, though it may not be mandatory. There is a certain curve and there is a space between the iris and the lens, but still in the immediate post-operative period, not to have any this thing, a PI would definitely be recommended. And the second one, that you use the normal biometry, the A constant, depending on the lens, it's about 117.2. What was that the second question? Sir?
Instruments.
Yeah, that is also the question, that would you change your IL power and what forceps would you use?
So obviously the A scan has to be, I mean, you have to input the A constant depending on the IL you're using. The one which we commonly use uses an A constant of 117.2. Other than that, forceps, just any curved forceps will be quite comfortable in ensuring that you're...
Any good IL holding forceps, but you can have the right side and the left side one, or you can have the universal T-shaped one.
Universal T-shaped one will also help.
And what lens are you putting? What manufacturer shares? 1 minute, Mohan Rajan, sir.
The one we are using is from Excel Optics, sir, but there are other options. Also.
Is it angulated or is it plano?
It is angulated.
It's posterior angulated, right? And what's the optic size and what's the total size?
So it is the overall diameter is 8.5 to 9 millimeter. The optic diameter is 5.5 to 6 millimeter.
5.5.
The optic diameter. So that
there has been
you need a 5 to 5.5 millimeter incision to push it in. So that's probably the only other.
Dr. Ravijit and Daljit used to use smaller optic and smaller overall size, and they thought there was an advantage to it, and there may be some, so we can't go into that debate right now. Quick last word from Dr. Mohan Rajan, and then we go on to the next debate.
Tell all the delegates that keep an inventory of ACIOLs is very useful. Don't please...
inventory of iris clips, sir.
Inventory of iris clips. Of course. Of course.
Okay, thank you, sir. And we are going on to the next situation. Thank you all the speakers for this very wonderful discussion. And before I go on to the next one, we've had a lot of votes coming in. We have lots of votes for retrofixated. We have quite a few votes for ACIOL in special situations, and we have votes for glued IOL. But then everybody suggested that, Dr. Ritika, how much time does it take you to do, and how much time an average surgeon would take? So essentially, what you're proficient with, I think you can do all three if you're following all the right steps. And before we go on to the next speaker, and we'll invite the next two speakers to please log in, I want to tell all the audience that we will be having our next IRSI webinar. Also, we have two webinars coming up actually. So the next one, which is coming up, is on the 21st, which will be on premium IOLs, case-based discussions on how to choose which kind of premium IOL, which will include multifocals, EDOF, the eye-hands kind of lenses, the toric lenses, and decision-making and dilemmas. So please log in on the 21st. And then we have another one, which is an international symposium, which is lined up by Dr. Amar Agarwal and Dr. Ashwin. And it's a joint symposium between AIOS and IRSI. And that is going to be on the 26th, where we will have international speakers. That's on iris repair and iris, different procedures on the iris, including the pupilloplasty, the iridodialysis repair. It's going to have wonderful audience, including probably Aiki Ahmed and a few other speakers. So, and then, maybe a week or 10 days online, we may have a AIOS and international OPL done by Dr. Amar Agarwal as well on the IRSI platform. So, yes, Dr. Mahipal.
There is nothing on iris fixation, iris surgery. The 26th is an OPL.
Oh, so the thing has been changed to OPL now, 26th?
28.
Dr. Amar sir, actually on 26th, there is probably an iris repair thing, and the OPL is for another date, I think. That's 28th or something. But we'll announce it. I think Dr. Mahipal will be on the air every day. He will announce the dates to you. He will know almost everything, which is
26th and 28th. It's 26th.
Right.
Gaurav.
26th will be iris repair, and 28th will be the OPL, which is going to be unique. We'll have combined AIOS, IRSI, and an international audience and a lot of international speakers. Yes, Dr. Keiki.
I just, we would like to say hello to everyone.
Hi.
Wonderful, ma'am. Good to see you. Thank you for joining us. And, good health to you. So good to see you. Thank you. So we'll quickly go on, sir, and we'll have Dr. Purendra Bhasin to make his case. Now the situation is simultaneous bilateral cataract surgery, and this is going to be our most important goal. So the audience, please remain ready to your comment section. We have almost 500 comments coming in on Swarnim. We have 200 comments coming in on the YouTube channel and another 100 odd on the Facebook. So we've crossed almost 600-700 comments, and we already have about between 3,500 to 4,000 viewers. And I think by the end of this, we'll have even more. Dr. Purendra Bhasin, you can please uplink your presentation, and we'll take a poll on whether you would like to do simultaneous bilateral cataract surgery, especially in the post-COVID era, when we are going to take lots of precautions, operating patients, we might be using PPE, we might be having to prepare the OT. So there is a bigger case for simultaneous bilateral cataract surgery. Dr. Purendra Bhasin.
Okay.
From Gwalior.
Yeah, I have to go first. Thank you, Gaurav. Am I audible?
Yes, go on, but go to slideshow, Dr. Purendra. Yes, now we have your slideshow. Thank you.
Yeah, thank you all. Thank you, IIRSI, Dr. Mahipal, Dr. Keiki, Dr. Amar, and everybody, and to my worthy opponent, Dr. Cyres Mehta also. And I will be speaking on post-COVID. Will you consider simultaneous bilateral cataract surgery as an option? I will be voting for no, and why I will follow. This will follow in my presentation. I have no financial interest. Instantaneous sequential bilateral cataract surgery or simultaneous bilateral cataract surgery, why it is suggested, why it is more popular nowadays. It says that there are a few patient benefits because of the convenience to the patient. It is cost effectiveness and better compliance with post-operative medications. In debilitated patients and special situations such as pediatric cataract and Down syndrome requiring general anesthesia. There is a study by Dr. Steve Arshinov, who is a major proponent for this surgery, regarding the financial differences. It should be clarified that the cost-saving opportunity should not influence the type of surgery or the way it should be done, which should be the basis on the medical consideration. So I think we should always look at the medical consideration than to the cost saving. Another thing is that the Royal College of Ophthalmologists from UK, they said that there should be a caution while taking a decision to perform immediate or simultaneous bilateral cataract surgery. It's not justified on convenience only. Another study which came in Journal of Cataract and Refractive Surgery in 2013, which suggests that a more detailed IS-BCS protocol is also needed to better define high-risk patients versus those who would most benefit from IS-BCS. Then the benefits and risks of immediate sequential bilateral cataract surgery, a literature review was done, and it has been published in Clinical and Experimental Ophthalmology in 2015. the risk of bilateral endophthalmitis, that is the most common reason which dissuades ophthalmologists to not perform IS-BCS. Authors surmise that the lower infection rates with IS-BCS which were presented in their studies are due to the most due to the careful patient selection process, precautions taken, and expertise and experience of the cataract surgeons performing this. Stronger and greater evidence is needed to support IS-BCS before proposing its widespread adaptation in healthcare jurisdiction, bearing in mind that only 3 randomized controlled trials have studied the safety and efficacy of IS-BCS to date. Another study with a meta-analysis of immediate sequential bilateral cataract surgery, which was published in 2015, concludes that we cannot provide evidence-based recommendations on the use of IS-BCS due to the lack of high-quality evidence. Therefore, the decision to perform IS-BCS should be taken after careful discussion between the surgeon and the patient. Recently, in April 2020, means this month, iNet magazine has also debated now, which is more common now, that the regarding simultaneous bilateral cataract surgery, it says that the decision to perform SBCS ultimately may come down to a physician's comfort level, and this is the bottom line. So, friends, with this background of simultaneous bilateral cataract surgery in the present time, and with the advent of COVID, what will be the situation post-COVID-19? We all know because of the lockdown, there will be an increase in the cataract backlog in the country and everywhere. Therefore, I would prefer to rehabilitate and benefit more number of patients by operating one eye of a patient at a time. Even in a patient with bilateral mature cataract, I would combine the other eye surgery with his follow-up visit as early as 7th day, as patient by that time will develop symptoms and signs of COVID, if any, during this period. As we all know, there is a window period of 0 to 5 days. And then we have a early signs of post-op endophthalmitis can also be seen during this period. In post-COVID-19, it is observed that we all know, and it has been observed worldwide, that the ophthalmologists are at larger risks of COVID infection. Therefore, our aim now would be to reduce the hospital stay time of patients and their attendants, and to reduce number of visits of the patient and their attendants. In simultaneous bilateral cataract surgery, we need to see the patient more often, even for their slightest complaints, as we are always in a dilemma that patient might be having endophthalmitis or TAS or any other problem, or the bilateral or the unilateral cystoid macular edema, or there is any chance of infection. So we will have to call the patient every time. On telecommunication consultation, we cannot ask them, because then legally we will be at a challenge. Therefore,
Dr. we are running behind time. Can you summarize, please?
Yeah, DBCS at a later date after a week or month. During simultaneous bilateral cataract surgery, we need to follow strict protocols with PPE usage and separately for each eye. Further, in our country, very few ophthalmic practices are NABH accredited. Even less number have full NABH accreditation. Most OR setups are poorly developed. And moreover, we don't have endophthalmitis registry maintained in our country, and we don't have TAS registry also. So in our country, the risk is that SBS is not approved or recognized. And we all know that patients are having lawlessness, and we often see in our day-to-day practice and with our friends and colleagues at other places. Even if everything is good post-operatively, for any trivial issues, patient will have a chance to blame and harass us. Most important, defending ourselves in the court of law would then be more difficult. So to conclude, I would not like to have a sleepless night. I don't want to indulge myself in any litigation for the so-called advantages that it is cost-effective, convenient, and better compliance is there. I feel my worthy opponent has less confidence that the patient will come back to him for the other eye surgery. For me, there is no big no for SBCS. I would rather prefer to wait and do other eye surgery at a later date. Thank you. Stay safe, stay happy. Thank you.
Thanks a lot, Dr. Bhasin. Can you please unlink your presentation?
Yeah.
Can you stop slide sharing? And I'll request and I'll invite Dr. Cyres Mehta from Bombay to please come in. And he's the scientific committee chairman of the International Society for Simultaneous Bilateral Cataract Surgery and has been doing this for quite some time. And I'll invite him to, he's also a biker, a racing biker, and he has these amazing gizmos with him, which he loves to use. So let's see. Cyrus, go on, please. And we'll
Gaurav,
please stick to 5 minutes. We need to close this at 7 p.m. So
Gaurav,
please,
are the slides on the screen?
Yes, but we need slideshow. Go to slideshow.
Yeah.
Is that all right?
Yeah. Yes, please go ahead. Yeah.
Yeah. So thank you for having me here. And great to see Dad, Mahipal sir, Gaurav, Purendra, Dr. Mohan, Rajan, Shreyas, and everyone else, Ritika. So immediate sequential bilateral cataract surgery, ISBCS. So I'm going to keep saying ISBCS so I don't have to say the whole thing every time in the era of COVID. So I've been the scientific chairman of the International Society of Bilateral Cataract Surgeons. So let's see, why did we do immediate sequential bilateral cataract surgery usually with multifocals in the first place? And should we be only doing bilateral cataract surgery now for everyone, especially in these times of COVID? Patients expect them that we should give them vision that they had before they had presbyopia, which is why when I started doing the surgery 20 years ago in 2000, at the advent of multifocal lens technology, the array had just been launched and we were putting in bilateral arrays for nearly everyone. So we've been doing this for 20 years now. It's nothing new. Given a chance, no one wants to go back and forth to the OR twice. And I see this in my daily practice. Patient says, doctor, can't you just do two eyes together? Naturally, ISBCS with multifocal implants was always the best choice. Nowadays, I use new generation EDOFs like the Sifi, Lucidis, iHands, and Atilara because today's generation of people don't want to deal with glare and halos. But I still put in trifocals in the older and technologically challenged people who can't handle gadgets and want to read books for hours together. Let's look at ISBCS in detail. What are the tips that we follow? We operate one eye after a betadine wash, then we change gloves. And for the second eye, we use separate operating sets, trolley, viscoelastic, syringe, cannula. Everything is separate. Even the BSS is separate. So it is like operating two eyes separately. I can understand that in a small town, it's very difficult to do this and we may be using the same instruments here and there, but we can't do that in a big city with the threat of litigation and everybody watching over us. Then we wash the other eye with betadine, repeat. We always change the BSS pouch, even though we don't need to change the cassette because there is no scientific theory. There is no sense for that. So for safe ISBCS, if you're using a Centurion where BSS packs are expensive, use the second handpiece for the separate eye. And you have to use a separate pouch. So what you do is towards the end of the first pouch, you simply do one eye, then you change the pouch and then do the second eye of the bilateral patient with the new pouch. Conventionally, we've been seeing that we are taught that if you do ISBCS, you may get double the complications like CME in both eyes, Standoff in both eyes, TAS in both eyes, and refractive surprises. Nowadays, this is not really the case. If you see the literature review, starting back in 2002, in 2,715 cases, there was zero increase in corneal edema, CME, Standoff in bilateral or unilateral cases. And coming all the way down till 2016, where Sri Ganesh has published 2,384 cases, and there is zero increase. So Royal College of Ophthalmologists said this in 2010, but they are stuck in a time warp and they didn't even social distance, which is why they're dying like flies now. Depending on how things progress, we may have to ask for a negative COVID-19 report 2 days before surgery from every single patient. Now, imagine having to do all this paperwork and logistics before every eye. Better to do two eyes together. What if we do one eye and decide to do the other eye after 7 days, and in the intervening period, the patient gets infected as an incubation period? Is the patient going to get two separate COVID negative reports 4 days and 5 days apart at a cost of 4,500 every time? Or are we going to pay for that? Shall we bear the cost twice for PPE for all the 50 staff that are roaming around in the hospital and pay twice for that as well? So number one, minimize doctor-patient interaction is the thing that we have to follow today. You will meet the patient half the number of times, half the exposure to clinic staff, other patients, relatives, and half the exposure of the patient to public transport, because everybody is not going to come in his own car. So you must do ISBCS. Even without the threat of COVID-19, patients always did better with ISBCS. There was no ametropia to deal with multifocal lenses. There was no comparing the unoperated eye to trifocal. Patients see better and essentially heal in half the time than they had to do with unilateral surgeries. The choice is very clear in the post-COVID era. ISBCS is the new mantra. When the patient comes, operate both the eyes and send them back. We still do unilateral cataract surgery if the other eye has already been operated. Thank you.
Thanks a lot, Cyres and Purendra, for really making your points so nicely. And there were a couple of questions that how about insurance and TPA? Will they compensate? Will they pay for both? And there was, of course, the second question was that will we be needing to do COVID tests? That we'll take that later. So have you ever tried TPA paying for both eyes simultaneously?
Since last 20 years.
They pay for both eyes. Do you send a requisition for bilateral surgery? Absolutely. And do you get an approval? Wonderful. So I'll take this question to our panelists. I'll invite again Dr. Keiki, sir, because Cyres has just spoken. Sir, do you do simultaneous bilateral cataract surgery as well?
Yes, I was the one who started it right in the beginning.
And Cyres carries the mantle forward.
A very horrible thing, but I would never been wrong with it.
Have you ever had a single instance of a complication which happened in both eyes, or a mismatch or a refractive surprise happening, and then you maybe with a multifocal and you got the refractive surprise in both eyes?
If the refractive surprise has occurred, then it can be corrected as you would correct with a single mono eye. There's no problem. Right. And the second most important thing to realize is there are certain guidelines which are laid down by the International Society for Bilateral Cataract Surgery. You don't take cases which are out of the ordinary. You take only very straightforward cases. And if you have a complication with the first eye, you stop there and don't do the second eye.
That's right. Wonderful. Thanks, Dr. Mohan Rajan. Do you do simultaneous bilateral in some cases?
I don't do simultaneous bilateral cataract surgery.
Not yet, at least.
Not yet.
Sir, you intend starting in the post-COVID era?
I have seen a video of Dr. Mohan. I've seen a video of Dr. Mohan Rajan doing two eyes together at AIOS during OPI.
Yes, absolutely. Absolutely.
That was not only simultaneous bilateral, it was two eyes at the same time.
Dr. Rajan, he has caught you on the back foot today.
Simultaneous bilateral cataract surgeons.
Yes.
The first in the world. And only in the world.
Suddenly he has become a proponent of ISBCS, huh? So, absolutely. Okay, Mahipal, sir. First thing, for two questions for you. One is that do you do sometimes simultaneous bilateral, and will COVID testing become a norm following this COVID period, lockdown period, prior to doing cataract surgery or any other eye surgery for that matter?
Okay, so just a simple answer for the first thing. I prefer my OPD to remain full. I don't have as many patients as Keiki and Cyres has. So I prefer them coming again and again. So in any case, I don't do bilateral, and I don't think I'll switch over to bilateral. Regarding COVID testing, I think yes, the positivity being about 70 to 75%, there could be a possibility that the person may say that I came COVID negative, and that's for the false negative, and you going back as COVID positive. But I think that is something that has become the norm in multi-speciality hospitals, because there have been several cases who came in with a cardiac ailment or for dialysis, liver transplant, etc., and they were actually COVID positive. So I think as the test numbers are going to be available, because just now you don't have the rapid testing, etc., available in those many numbers. Once you have them, I think it may be a better idea, and the cost may go down. It may be a better idea to have a person tested for COVID before a person comes in for a surgery, especially if the person has to undergo a surgery under GA.
Sir, there was a quick question because, HIV testing has been very controversial, and, there has been a thought that you cannot actually get HIV testing done compulsorily for all patients undergoing cataract surgery, and nor can you charge the patient for getting that HIV testing done legally. I had read about this somewhere, and there was a big discussion on this. Do you think COVID testing, if a patient refuses to get his COVID testing done, will you refuse that surgery?
Yes, as of now, there is nothing like that. At that particular time when HIV testing and all was said that you are intruding into the privacy of a person. So they said that you can't really, if he does not want, so you are not legally allowed to force him. But I think that has disappeared. So no patient, if you write the test for hepatitis A, B, C, and you write for the HIV also, no patient says no. So as of now in the COVID times, the guidelines of ICMR does not allow you to actually go in for routine testing for a person who's asymptomatic. That's the only thing. So we are in two minds from AIOS whether to give out this thing that you should get a COVID testing done or not. I think it is still early days, but COVID is going to stay with you. It's not that till the vaccine comes, it's going to stay with you. So it's going to be at least 6 months to 9 months or 12 months before a vaccine comes. So it may not be a bad idea to actually get an elective COVID test done for people coming in for surgery.
And the cost has to be, of course, passed on to the patient. That's 4,500 for now. And maybe if we get rapid testing, it might become a little cheaper. And so, yes, Dr. Mohan, please.
I'm doing COVID tests for all, even my emergency patients.
So actually, there was a patient.
It's not available everywhere.
It's available here in Chennai. In the private labs, it's available. So I'm making sure that the patient's having the COVID negative before they take them up. Even the emergency surgery is what I'm doing currently.
So there was a patient who came in yesterday.
I ask Mahipal and Keiki, sir, also, in the post-COVID era, if you're not doing bilateral simultaneous now, in the post-COVID era, I think it makes sense to do a bilateral simultaneous because the patient interaction is going to be less. The number of times the patient is coming to the hospital is going to be less.
But sir, the thing is, if anything develops, it will be on if the patient has something wrong. Maybe IOL power calculation, wrong IOL power calculation or anything. Dissatisfied patient can always trouble us more when we do both eyes. Because it is not a legal thing as of now.
The patient goes to the court, then he says this is not the standard operating procedure.
Yeah.
That's the basic problem. Today, if you have from all the things, it is not a standard operating procedure. If he has complication in both the eyes, he says you actually did something which is against the norm.
So nobody will be able to say.
So I have a very interesting question from the audience.
I have a point for that, Gaurav. That's why the society was started. So there is an international society, etc., with laid down norms, and it's accepted by the Canadian Ophthalmic Society and also by ASCRS and other bodies. So that's why the society was actually started for legal recourse in Canada, because Steve Arshinoff wasn't getting reimbursed when he operated two eyes together. And he was the guy who started operating two eyes. That's why they started the society. So as far as legal recourse goes now, we can always quote the society and say that we have so many thousand members and everyone is doing it. That's the whole idea behind the society.
I take your point. There's a very interesting question, Mahipal sir. What if a patient whom you are suggesting to get a COVID test done, what if he says that doctor and staff, have you had your COVID testing done before you operate upon me?
That's exactly this question what I was going to say, because yesterday only, the day before, there was a patient of RD which Lalit has to operate, and he says, is your staff tested for COVID?
So this is going to be tough. You know, the surgeon may have to get his credentials to show as well. And, we have only a few minutes left. I'll try to pull in all our, panelists who were, all our speakers who have been with us throughout, all our 16 speakers. There has been tremendous discussion on all 4 cases, and we've had excellent, we have actually almost 500 questions on our Swarnim portal, 400 plus, and we have another couple of hundred on the Facebook and YouTube. What I'm going to do is I'm going to download this as a PDF, or this is for the benefit of all the audience. I'm going to download a PDF of all the questions which were put up. I'm going to mail them to all our speakers. There are questions for all of you which we could not take up, and there are email IDs for all our people who have asked the questions. There are very nice, good questions which we could not discuss. So as a service to all our attendees, what I'm going to do is I'm going to send the PDF to each one of you, and please try to answer the questions relevant to your topic on email to these people. This will be good because that the whole purpose of the seminar will be served, and I'll be grateful if you can send out the responses. And we'll have Dr. right from the beginning, I think Dr. Rohit, Dr. Bharti, and then Suven, and we had tremendous discussions on all 3 subjects on the BHEX and the other 2 techniques on the small pupil. We had excellent discussions. Yes, Dr. Mahipal. I think Dr. Mahipal has to go and join. A quick word from you before you log off, sir.
Excellent as always. Thank you very much, everybody, and stay safe, stay happy, and maybe you can continue for 5-7 minutes more if you want.
Yes, we will probably continue for another 5 minutes. I'll allow, if anybody wanted to put in a, thank you, Dr. Mahipal, sir. Anybody who wanted to chip in a little bit on something that he felt that he could not make a point, we'll allow. Anybody who wants to do it can please comment right now from amongst our previous speakers. Dr. Rohit wants to say something. You're on screen, sir.
Yeah. I think it was a brilliant idea which you have come up with all these webinars. Talking about the moxifloxacin and all. I think we have a study of around 27,000 cases wherein we have not used intracameral moxifloxacin for that matter. Pre-operative and operative betadine, as Dr. Mahipal was saying, there's so many things which we at times are overlooking, and we feel that when we are using moxi, we can do away with all those. Strict OT protocols are also a very important factor in all the, when you decide about intracameral moxifloxacin or not. That part has to be definitely taken into consideration.
I agree, Dr. Rohit, completely. Dr. Bharti was trying to say something quickly. Dr. Bharti, sir, any quick comment before we wind up?
Not really. I was not trying to say something, but one thing which comes into mind is we have to every time must consider as to what is good for everyone and not in the hands of the best surgeons, which we invite as a speakers. So when I talk about it, I think the easiest procedures should be more, propagated, like antechamber IOLs, and like I said about iris hooks or any such thing which is very easily acceptable by a surgeon sitting in a remote area. And also the second thing is about the OT protocols. OT protocols are so good these days that I think we have to balance the benefits vis-a-vis the problems with the antibiotics which you put in a higher concentration in the intraocular fluids. So those 2 points were, I think, I want.
I think the points are very well taken, sir, and they are very valid. There was also a question about how much the BHEX costs. I think, Suven, if he's still online, we'll take quick vote from you. And which are the forceps which you recommend? So very quickly, Suven.
Yeah, the BHEX now costs 1,500 plus GST. If you buy a pack of 5, it's 1,500 plus GST each. And if you buy one singly, it's 1,800 plus GST. And the forceps cost 7,000 rupees inclusive of GST.
And where is the forceps? Who all are making the forceps?
Yeah, actually, we have some of the forceps, and Georgia Surgicals is one of our distributors who's selling the forceps.
All right. Thanks, Suven. So that's quite an inexpensive ring as well, and I've used it quite often, and it works really well, except in the very small people. There was a quick question. Somebody had asked that is there anything against doing multiple small sphincterotomies? I know, Suven, you have been talking about it for very small pupils, but I'll ask this question from somebody else who was on panel there. I'll ask if our moderators are there. Is Dr. Mohan Rajan still there? Or Dr. Keiki. So would you use micro sphincterotomies? That was a question for very small and rigid pupils, or would you plan to do a stretch? Anybody would like to comment? Even Dr. Rohit, I'll ask her to comment on this quickly.
Are you able to hear me?
Yes.
No, I will not do a micro sphincterotomy, or I will not do a stretching of the pupil also. Very small pupils, the BX or the Mulligan ring does not work in my hands. So I would prefer to use iris hooks in such patients.
So I'll stop here and I'll ask anybody amongst the panelists.
I agree.
Anybody amongst the panelists who would like to do micro sphincterotomies or pupil stretch, who's in favor of doing them?
Gaurav.
I do pupil stretch.
Yes, Ashu, you first. Ashu and then Cyres.
Okay, Gaurav. So of course, in this era of the rings and the hooks, one doesn't need to do it. But I think about 20 years ago, most of us were doing it. We used to do a micro sphincterotomy and stretch, and it used to work well. But of course, the thing is, it's you are distorting the pupil. So if nothing is available, it will still work.
Cyres? Yes, Cyres.
So when you put iris hooks, actually, if you look at the pupil, you've created multiple little sphincterotomies anyway. So that's why the pupil becomes nice and big. And that's why I still prefer to use iris hooks, even though the rings are wonderful devices and all. I'm still comfortable with iris hooks because it gives me a nice big area to operate with.
Gaurav, I would like to do sphincterotomies or using the stretching of pupil in cases where there is a thick membrane present in uveitic cataracts, especially in uveitic cataracts. Because once you put the iris hooks and these rings, then it doesn't work well. So in such cases, which are very rare.
There is another question. Yes, Dr. Rohit.
Something, yeah. I just want to add, if the ACD is less than 2.5, in those cases, I prefer not to use a Maluguin ring, number one. And when the pupil size is very small, you have to stretch it so that before you can put a Maluguin ring or not. There are two models of
Somebody's mic is on and needs to be switched off. Admin, can you switch off the mic of somebody?
So
some announcements coming from somebody's. Yes. Okay. Somebody's at the railway station, it seems. Okay.
Yeah. So these are the points you know what you have to, because if the pupil size is 2, you cannot use a Maluguin ring. You have to stretch it before you use. And the original ones, the one model, and the second is the newer one, Maluguin ring, which has come up. In stiffer corneas, stiffer irises, you cannot use the second one, the newer one. The first one of the better ones.
It's polypropylene.
Can I have a last word, please?
Can I make a comment?
Yes, Anagha.
Yeah, as sir was saying regarding the anterior chamber depth being smaller, in fact, if you use iris hooks, then you are in fact reducing the anterior chamber depth in the periphery. In a Maluguin ring or a BHEX ring, in fact, it is you would not be changing the anterior chamber depth, I think. And another thing, I had a patient with IFIS who wanted a multifocal IOL. And I used the BHEX ring, and it was an excellent experience, and there was absolutely no problem, and we could manage the case. And next day post-op, the pupil was nice and circular, and it really worked very well. So in these cases, using an iris hook, you can end up having sphincter tears, and with multifocal IOL, you cannot afford to have that.
Thanks. And there was a quick question on the same subject. Somebody has asked that intraoperatively, if you have already done the rexis and you are cracking the nucleus, and at that stage, suddenly you have a pupil coming in and, becoming very small and nothing else works, including viscoelastic and phenocaine and adrenaline and everything, then what is better to use, a ring or a hook? Who would like to answer this?
Gaurav, me?
Doctor? Yes, Suven. Okay.
Yeah, so I showed that in the last video that when you're using yours, if you have intraop minuses, that means that pupil is not fibrotic. So when you use a BHEX, you can see the notches so clearly. So when you engage the pupil margin and you advance the flange under the pupil margin, you have capsular rexus margin has not been engaged. So that is a very advantage when you're using BHEX compared to the Maluguin ring, where actually you can engage the capsular rexus margin. Now coming to the pupil size and the rigidity, see there are, unfortunately my slides didn't show them. There is a rigid pupil and there's an elastic pupil. So try as much you may. In a rigid pupil, you cannot stretch it; it's going to tear. So what means you use to tear is up to you, whether you want to use microsphincterotomies, stretch, or an iris hook, or a Maluguin ring. Yes, the BHEX is not bulky enough to tear the pupil margin. So that's why we recommend a bimanual stretch in a rigid pupil and then use the BHEX ring. That's simple.
Excellent point, Suven. And here I'll add something because I personally had a problem with Maluguin's ring. I love the Maluguin's ring. I also enjoy the BHEX. So what I've found is that intraoperatively, we had a sudden very small pupil, and putting the Maluguin's ring, which is blind procedure because the pupil had come down to just about 2 mm. It went and caught the rexus edge, and I was almost going to have a rexus tear, and I just managed to see it. So what I'll recommend is that if intraoperatively suddenly you decide to put in any of these rings, it may be a good idea to first wash out the viscoelastic, put in 2 drops of trypan blue under the pupil so that your rexus edge gets stained. And then after that, under viscoat, so that you've stretched the pupil as much as you can. And then you can engage one of these rings by lifting the, iris up a little bit with a white tip spatula or something, so that, you have exposure and you can see in the area whether you're catching the rexus or not. You can stretch the pupil a little bit in that area where you're going to engage the, Maluguin's ring or the BHEX notch. And you should be able to see that under visualization that you're not catching the capsular rexus edge. Otherwise, personally, I prefer to use the iris hooks when I'm caught in a situation intraoperatively over the rings, because it seems to me to be more controlled, yet it's what works best in your hands is what works best. So unless there is some very important question, I think we've exceeded time. If there's something which anybody would like to quickly raise before we sign off, for the benefit of the audience, as I said already, we have a premium IOLs case-based discussion on which IOL is best for a particular situation. We'll have some top experts, sharing their cases for discussion with the panelists. That's on the 21st of this month at 5 p.m. Then we have on the 26th and the AIOS IRS international symposium on iris procedures, including iris repairs and iridodylisis repairs and many other things. And then the OPL, which Dr. Amar Garwal will be hosting on the 28th. So any quick question from any of our panelists?
I just want to compliment all the speakers for the fantastic talk.
And
thanks a lot, Dr.
Thank you,
Mohan.
Dr. Gaurav, for such a
Gaurav for coordinating this.
Fantastic moderation.
Yep, absolutely.
Thank you so much. You don't have to thank me. I think I have to thank all the speakers who took out time, and they've contributed so tremendously and prepared so hard on short notice. We just gave you less than 1.5 to 2 days to prepare for this presentation. So I would like to thank each one of you who took out time to be on the panel or to prepare your talks and delivered them, and for all the audience for joining us for these IRSI symposiums. And we will keep coming back to you every few days during the lockdown period. So please watch out. We have a very active Facebook page and we have a very active YouTube channel, and we will be reaching out to you in many ways. And if you would like to suggest any topics that you would like us to cover in future webinars, please don't hesitate to email me. My email ID is drgl2020, drgl2020@gmail.com, and my phone number, of course, is available on the various forums. So thank you so much, all our panelists. I can see that we have most of our panelists are still on board with us. So each one of you, Dr. Ritika, Dr. Shreyas, Dr. Ashu, Dr. Haripriya, Dr. Anagha, all the speakers, Dr. Rohit, Dr. Bharti, I don't want to miss out on anyone. Thank you so much, Cyres, Purendra, all our panelists, please for joining us. And now we'll all sign off. And of course, last but not the least, the people who are behind this and who've made this possible and who work very hard to make this show successful. They work almost continuously for 2 days, doing the trial runs and setting up the links and setting up the backgrounds. So much work. Jaswinder and Gaurav from the J&J team and the whole J&J team who have been kind enough to sponsor all our symposiums for us. Thank you so much for doing this for us, and I'm grateful for all your help. And please do helping us in future webinars also, and see you soon on another webinar. And we are all signing off from here. Thank you so much. Whole J&J team who have been kind enough to sponsor all our symposiums for us. Thank you so much for doing this for us, and I'm grateful for all your help. And please do helping us in future webinars also, and see you soon on another webinar. And we are all signing off from here. Thank you so much.